Selamat datang kembali di The Third Jakarta Endoscopic Ear and Sinus Surgery Course. Selanjutnya, tanpa berlama-lama lagi, kita akan memasuki sesi ketiga yang akan dimoderatori oleh Dr. Rangga Rayendra Saleh, spesialis telinga hidung tenggorok bedah kepala leher, subspesialis otologi konsultan. Dr. Rangga merupakan staf medis Divisi Otologi Departemen THT BKL FKUI RSCM. Dapat disaksikan pada layar CV singkat dari Dr. Rangga.
Welcome back to the third Jakarta Endoscopic Ear and Sinus Surgery course. Without further ado, we will begin the next session, moderated by Rangga Rayendra Saleh, MD, ORL HNS. Dr. Rangga is a medical staff of Pathology Division, Department of ORL, HNS, Faculty of Medicine, University of Indonesia, Cipto Mangunkusumo National General Hospital. On the screen, we can see a brief CV of Dr. Rangga.
Kepada Dr. Rangga, waktu dan tempat kami persilahkan.
Assalamualaikum warahmatullahi wabarakatuh. Selamat siang, selamat datang kembali dalam acara Third Jakarta Ear and Sinus Endoscopy Surgery Course JE2S. Kita memasuki sesi yang ketiga pada hari yang pertama ini. Untuk sesi yang ketiga ini kita akan mendengarkan ada 3 topik yang tentunya tidak kalah menarik atau mungkin bahkan lebih menarik dari yang tadi. Itu adalah mengenai kasus-kasus yang lebih advance atau penggunaan endoscopic ear surgery untuk kasus-kasus yang lebih luas. Mungkin bisa ditampilkan CV pembicara kita untuk sesi yang ketiga ini. Yang pertama tentunya sudah kita kenal bersama Dr. Philip Rajan. Beliau adalah subspesialis otologi dan neurologi dan juga saat ini sebagai honorary lecturer for University Malaya, University Science Malaysia, University Kebangsaan Malaysia, dan juga adjunct professor di Taylor's University. Kemudian nanti pembicara yang kedua, our second lecturer will be Professor In Seok Moon from Yonsei University College of Medicine. So Prof Moon is a neurologist from the Department of Otolaryngology. Dan kemudian so Prof Moon is also the chairman from the Department of Otolaryngology Gangnam Severance Hospital and also professor from Yonsei University College of Medicine. Kemudian untuk pembicara yang terakhir di sesi ketiga ini adalah Dr. Diana Rosalina yang juga sepertinya yang kita sudah kenal bersama. Dr. Diana Rosalina adalah otologi clinical teacher dan konsultan di Rumah Sakit Fatmawati Jakarta dan juga clinical teacher untuk medical student di University of Islamic Nation Syarif Hidayatullah Jakarta. Untuk itu saya persilakan untuk pembicara yang pertama, Dr. Philip Rajan. Please, Dr. Philip Rajan, time is yours.
Okay, selamat petang dan salam sejahtera sekali lagi. So semua sudah makan dengan baik, sudah kenyang. So kita akan sambung kepada sesi yang ketiga. So terima kasih Dr. Rangga sekali lagi. Okay. So tajuk saya pada petang ini ialah endoscopic assisted cochlear implantation. Okay, so pertama sekali report tentang endoscopic cochlear implant keluar adalah pada tahun 2014. Dan antara pengarang publication ini adalah Dr. Joao Flavio Nogueira. So memang dia seorang yang terkenal di bidang endoscopic ear surgery. Okay. So dalam penerbitan itu ada 25 case multi-center study. Okay. So the first published paper on endoscopic cochlear implantation, a large series of 25 cases. Okay. So cara yang dia buat ialah exclusively transcanal. So follow up adalah untuk 16 bulan. Okay. Dan dia buat, kalau kita tengok, incision dia adalah actually post-auricular. Okay. Tetapi transcanal, but transcanal. Okay. And then dia mengambil satu flap, pedicle flap, dan dia gunakan flap itu untuk tutup elektrod di bawah ear canal skin, ear canal kulit. Okay. Tapi what happened? 6 out of 24 cases, maksudnya 25%, 25% of the cases visible through the skin. So ini adalah satu gambar 2015 di Sydney. So ini adalah kali pertama saya pergi untuk endoscopic ear surgery workshop. So masa itu Dr. Nogera di sana, okay. Dr. Nirmal Patel, Tara Bichi, I think somewhere here. Okay. Tak boleh nampak mana Tara Bichi. Okay, ini adalah saya. Okay. Mr. Tengku Izam, I think si orang kenal Tengku Izam pernah datang sini. Okay. So this is a big workshop in Sydney, and memang pada masa itu kita tanya Tara Bichi dengan Nogera, what is your experience with endoscopic cochlear implantation? Sebab memang semua orang nak buat, semua surgery pun endoscopic masa itu. So Tara Bichi said, Philip, stop, don't do this. Okay? Sebab dalam experience dia di Egypt, di negeri Arab, ada banyak surgeon, many surgeon buat endoscopic cochlear implant with complication. He said, I terpaksa buat banyak revision cases. Okay? So the problem is success diterbitkan, tetapi failure atau apa yang gagal tidak diterbitkan. So kita pun tak tahu. So sometimes we want to try because we think it is good. So Tara Bichi telah terbitkan satu publikasi dan di mana dia telah review 100 CT scan. So dalam kajian ini dia mendapat the posterior tympanotomy aligns more favorably with the basal turn of the cochlea than transcanal access. So memang daripada posterior tympanotomy kita buat cortical mastoidectomy, posterior tympanotomy, bila kita masukkan electrode ke dalam round window ataupun cochleostomy, dia memang straight. But kalau you buat dari ear canal, it is not straight. Electrode itu terpaksa bengkok. Okay? So now there is a problem. Sekarang kita tahu electrode yang baru, kita ada soft flex lah, sim flex ke apa-apa, it is very fragile. Kalau bengkok sikit memang tak boleh masuk. Okay? And then you have to manipulate the electrode. You terpaksa pegang electrode itu and that can damage the electrode. Okay, so that is a problem. Okay? So he said endoscopic technique not useful. Okay? So so masa itu in 2017 I did a study dengan Profesor Prabhakaran dengan Tengku Izam juga dalam kumpulan kita, Prof Tang Ying Peng. Kita telah kaji, kita buat satu literature review. Okay, kita kaji semua publication tentang endoscopic cochlear implantation. Okay. So saya nak beritahu sesuatu di sini. Kalau you write the paper, kalau you nak terbitkan satu artikel, be careful. Okay. Walaupun artikel ini diterbitkan dalam Springer Journal, you tahu sekarang ada journal, you nak publish, they will tell you, if you want open access, bayar $3,000. Betul? Kalau tidak, tak ada open access. Yeah, so journal ini macam itulah. So masa itu kita nak publication. Okay, we want the publication, but we cannot pay $3,000. So it remain non-open access, and journal ini memang tak ada orang baca. So that is dangerous. Be careful lah. Mungkin you junior, you nak publication saja, tak apa, tak bayar duit, tak apa, then you dapat publication nanti orang tak baca. So that is a dangerous thing. So be careful. I don't like, saya tidak suka journal yang buat macam ini. Ada yang memang open access, ada yang macam New England Journal of Medicine, after 3 months they make it open access. I think that is fair. Memang journal pun ada cost, but they don't leave it closed forever. So be careful when you want to publish something. Sometimes you may have something good, tetapi you publish dalam jurnal macam ini, habis orang tak baca you punya kajian. Okay? So dalam kajian ini kita telah check semua publication sampai masa itu, and terdapat 7 publication. Okay? So kebanyakan round window atau cochleostomy. Okay? 27 menggunakan mastoid buttress. Maksudnya cortical mastoidectomy digunakan untuk walaupun transcanal, mereka masih buat cortical mastoidectomy. 25 menggunakan bony groove in EAC. Okay. 34 normal ears, 11 abnormal ears. So what is the finding? Okay, ini adalah complication. 20% satu daripada 5 kes kulit pada external canal ataupun tympanic membrane telah koyak. Okay. 5% ada cauda tympanic injury. Then the rest is one case each. Okay. Tak ada facial nerve palsy. So this kenapa orang suka buat transcanal? They feel kalau you buat posterior tympanotomy mungkin akan cederakan facial nerve. So bagi surgeon yang tak berapa experience, they feel this is better. No risk to facial nerve. Tak ada risiko untuk cederakan facial nerve. But ada banyak komplikasi lain. Okay. So remember tadi Dr. Rangga ceritakan tentang anatomy. Satu daripada anatomy paling penting ialah kita panggil kawasan round window niche. So ada, this is your anterior pillar, posterior pillar, ini adalah tegment atau roof, dan ada satu macam club sini, ini dipanggil fustis. Okay, fustis. So ini anatomi sangat penting. Okay, if you have, kalau you tak tahu di mana round window, cuba cari anatomi ini. Okay, dan ini adalah satu indication, dia akan point to where the round window is. Okay, so cari fustis itu. Okay, so satu daripada case report ditulis oleh Macchioni. So memang kita tahu dia yang tulis buku anatomy untuk endoscopic ear, middle ear anatomy. So he says endoscopic approach for cochlear implantation in advanced otosclerosis, a case report. So dalam case dia, again dia pakai ini fustis, tegment, anterior pillar and posterior pillar. Okay, ini kita tahu subiculum and funiculus. Okay, so dia menggunakan ini sebagai to find the round window area. This is round window area. This is fustis. Okay. Then dia drill sampai otosclerosis itu ditebusi. Then dia buat implant. Macam mana dia buat implant? Saya tahu mungkin you tak berapa appreciate, so saya lukis sikit. Ini adalah external auditory canal. Ini adalah cortical mastoidectomy. So implant actually masuk ke dalam cortical mastoid, keluar ikut sini dan masuk ke dalam cochleostomy. Okay. So ini apa yang kita panggil mastoid buttress. So ada tulang, there is a bone that protects the electrode. Okay. Then dalam case inner ear malformation, again daripada Macchioni punya kajian. So dia pun buat endoscopic transcanal. So dia cuba cari mana, where is the round window. Ini round window. Okay, dalam abnormal anatomy. Okay, so this is the promontory, this is the oval window. Okay, so this is the fustis. Okay, so this is the area of the round window. And then dia buat cochleostomy sini. Okay, so he open up the cochleostomy. Okay, remember tegment, anterior pillar, posterior pillar, and the fustis. Okay, so dia open up, dia buka, and dia menggunakan itu untuk masukkan electrode. Okay, so this is the reported cases. So ini saya nak tunjuk satu case yang dibuat di KL. Ini case ini bukan saya buat, Profesor Prapagaran buat. Okay, again inner ear malformation. Okay. So pertama sekali post auricular incision. Okay. Dan post auricular incision digunakan untuk mendapatkan atau untuk harvest temporalis fascia, untuk digunakan dalam operation semasa menutup electrode. Okay, so that is harvesting of temporalis fascia. Okay. Step kedua ialah elevating of EAC skin, kulit external canal diangkat. Dan lepas itu tympanomeatal flap untuk raise the tympanic membrane. Nah, ini bone dust atau bone putih. So dekat mastoid cortex kita ambil sedikit bone dust. Okay, dan simpan. So sekarang apa kita buat ialah dalam external auditory canal kita buat satu groove. Buat satu macam longkang. Nah, sekarang kita cuba cari mana round window. So bila kita tahu lebih kurang position dia, kita buat satu cochleostomy. Okay, so ini proses masukkan elektrod. Okay, dan elektrod dimasukkan ke dalam groove dalam external auditory canal. Dan di atas itu kita letak bone putih. Okay. So ini sangat penting. You must have a barrier, satu macam tembok atau batasan tulang supaya elektrod tidak keluar. Okay, bone putih, and then kita letak fascia di atas bone putih. And then tutup balik kulit EAC skin. So ini selepas 2 tahun dan kita letak cartilage juga di atas. So ini kita nampak, okay, tak ada extrusion. Okay. So yang sangat penting ialah elektrod itu mesti ditutup dengan baik. Okay. So kita pakai bone putih, skin dan juga sini cartilage. Okay. Okay, so endoscopic assisted cochlear implantation. Ini adalah lagi satu case. Okay. Saya buat masa di Ipoh, okay, 2 tahun lalu. So, tiba-tiba saya cuba cari mana round window tapi tak dapat. Okay. So saya tahu ada yang online sini daripada Sumatera Barat, dari mana-mana. Kalau katakan you buat cochlear implant, tiba-tiba tak dapat cari round window, apa you nak buat? So yang satu saya telah, okay, untuk mendapat akses yang lebih, you can remove, boleh buang incus buttress. Okay, remove incus buttress supaya boleh nampak dengan lebih jelas. Okay. Dan saya menggunakan endoskop untuk lihat di dalam middle ear. Okay. So ini adalah satu CT scan patient itu. So the scan shows a very well pneumatized area before the round window. Okay. So masa itu saya seorang, saya pun tak tahu apa nak buat. So saya ambil gambar ini dan saya panggil Profesor Datuk Lokman Saim. Okay, dia pernah datang sini kan, dia kita punya guru. So saya WhatsApp, "Hi Prof, saya ada problem sekarang, apa nak buat?" Okay, he said, "Okay, let me see the scan." Then he said, "Okay, you do this, you drill here, you akan cari this one." So dengan endoscope you can record everything. So this is another advantage. So kalau you ada problem di mana-mana sekarang yang online ke offline, kalau you buat case ada problem, jangan takut. Semua orang ada WhatsApp sekarang, boleh panggil Prof Harim sini atau mana-mana this one, just panggil and call, Prof Diana, Prof Dina, semua boleh panggil. Saya ada problem, apa nak buat? Okay, so they can help you. Orang boleh bantu you. So don't worry. Okay, if you have a problem, ada masalah, you can always call. So this is another use, kebaikan kegunaan endoskop. Okay, so ini adalah satu lagi case di mana saya ada problem mencari round window masa buat pembedahan. So sama seperti tadi, saya telah buang incus buttress dan masukkan skop ke dalam supaya saya dapat lihat dengan lebih jelas. Okay. So boleh nampak promontory sana. Okay, this is the promontory. Ini area hypotympanum. You nampak sini. So this is the round window area. Ada granulation yang memblock the round window opening. Okay. So dengan endoskop boleh lihat dengan jelas. This is the tympanic membrane, eardrum. Ini dekat annulus. Okay. So lepas itu, saya menggunakan drill untuk membuat cochleostomy. Okay. So bila sudah buat cochleostomy, lepas itu masukkan implant. Okay. So implant saya tidak masukkan dengan endoskop. Okay, saya just tunjuk saja video sini. Okay, kalau you nak masuk dengan endoskop satu tangan susah. Okay, microscope is still the best to hold, to manipulate. Okay, so just be careful. So ini untuk tujuan pengajaran, I just tunjuk sini. Okay, so memang endoskop ada kegunaan. Okay, so bagi saya, kalau you nak buat cochlear implant untuk dengan endoskop, isu-isu dia ialah satu ialah trajectory. Okay, so be careful. Kalau especially implant yang baru, dia very soft, soft leg semua, easily untuk di damage. So kalau you nak buat transcanal, perlu fikir hal itu. Kalau you terpaksa buat, maybe you have to use a stronger or firmer electrode. Okay, dan kalau you nak manipulate electrode, mungkin you akan damage the electrode. Dan ada isu electrode extrusion. Okay, kalau tidak ada proper coverage. So kalau ada bony buttress ataupun kalau you betul-betul pack dengan betul, ada isu extrusion. Okay, apa kebaikan? One, untuk yang ada congenital malformation, you dapat identify dekat mana round window. Okay, so saya telah menggunakan untuk actually membantu saya bila saya tidak pasti di mana round window. Okay, so this is good. Dan akhir sekali, kalau ada telinga yang bermasalah, congenital malformation ataupun dalam otosclerosis, apa-apa, memang menggunakan endoskop boleh membantu. Okay, itu saja. Terima kasih.
Terima kasih Dr. Philip Rajan. Berikutnya kita akan mendengarkan topik yang kedua. Topik yang kedua akan dibawakan oleh Prof. Insyuk Moon. Okay, good afternoon, Prof. Moon.
Hello. Good afternoon. Thank you for inviting me. I already sent my lecture video. So if you agree, can I run my lecture video and then I can do question and answer session? Is it okay for you?
Yes, Prof. Moon. Is it okay? You can play the.
Yeah, because it's very noisy in here. I'm sorry about that.
Okay, thank you, Prof. So we already get the video.
Hello, I'm In-sung Moon from Yonsei University, Seoul, Korea. Congratulations, Jakarta Endoscopic Ear and Sinus Surgery 2023. Today's my talk is about endoscopic transcanal approach for small vesicular schwannoma. For ENT surgeons, if the tumor has no serviceable hearing, translab approach using microscope is still standard option for vesicular schwannoma treatment. But if the hearing is not serviceable, why we need to keep cochlea and why we need to use this long and destructive way? For small tumor without serviceable hearing, transcanal, transpromontorial approach with endoscope can give alternative option. This approach is not for the translab or not for the transpromontorial transcanal. It's a lateral sigmoid approach, but you can feel the difference in the same surgery with different equipment. These two surgical videos were taken in same operations with minimally invasive lateral sigmoid approach. In left panel, you can see microsurgical field, and in right panel, you can see endoscopic view. For last 35 years, my department treated 762 acoustic tumor cases. I started my independent career, and the dark blue one is mine. And till now, my case series is a little bit more than 500. Still, 83% of patients were treated by translab approach, and only 27 were endoscopic approach, but I'd like to show this feasibility. The contents are like this. I'll introduce endoscopic transcanal approaches, and if time is enough, I will touch endoscopic keyhole midcranial fossa approach. But time is not enough. I'll only present endoscopic transcanal approach. First, transcanal approaches for tumor removal. This concept was introduced by Professor Daniele Macchioni from Italy. He first adapted this approach instead of translab approach. So we can use external auditory canal and cochlea as an alternative corridor for the vestibular tubercle removal. Originally, EAC closure as a cul-de-sac was introduced by him, but I modified a little bit to keep the EAC and performed cartilage meninoplasty. Of course, EAC not needed in that patient, but patient usually want to keep the normal anatomy. So you can see this for the post-operative tympanic membrane healed status. Let me introduce several clinical cases. First case is interlabyrinthine schwannoma, and very good candidate for use this approach for the first time. Tumor involved vestibule and basal tone of cochlea. Mid-tone and apical tone was preserved. After tympanomeatal flap elevation, ossicle was removed. The promontory was drilled, then the vestibule was opened. Open the promontory a little bit more, then you can see the tumor inside the vestibule and the basal tone of cochlea. This is a tumor inside the vestibule, I mean the utricle. A little bit more. After drilling, a small hole was made in the IAC and the CSF was cut out. I suck out and removed the tumor in the basal tone, then do the meninoplasty using the tragal cartilage and perichondrium. Second case is small vestibular schwannoma with depth. Let's watch the surgical video. After TM flap elevation, ossicles were removed, and then cochlear drilling was done. You can see the modulus in the upper side. This is tumor and facial lobe tympanic segment. This is a cochlear nerve is here. I just gently suck out the tumor. CSF gushing pushed the tumor, and the tumor was easily pushed out. This is facial lobe and cochlear nerve. After tumor removal, IH was packed with fat in the tragal area and surgical. Then cartilage meninoplasty was performed as same method. Next category was simultaneously tumor removal and cochlear implant. There is controversies about cochlear drilling even in that patient, because someone criticized that the patient can receive cochlear implant if we can keep the cochlea and cochlear nerve. Mostly single-site deaf patients don't want to get cochlear implant, and they can the other chance of the bone conduction implant for hearing restoration. But anyway, the criticism was happened. So I thought about that infrapromontorial approach for the bacillus pharyngeal removal in very small tumor. That means I just drill the cochlear basal tone, half of basal tone, and hypotympanic air cell merge, and then can remove the tumor in that corridor, and then we can do the cochlear implant using distal basal tone, mid tone, and apical tone. In this patient, I performed simultaneously bacillus pharyngeal removal and cochlear implantation. He has deaf hearing in tumor side and also moderate hearing loss in contralateral side. So cochlear implantation in tumor side was a better option than bone conduction implant in tumor side. So I decided to do the simultaneous cochlear implantation in this patient using infrapromontorial approach. Same as previous approach, ossicle were removed and cochlear vestibular junction and cochlear hook region and fundus IAC area drilling was done. Then you can see the cochlear entrance here, and half of basal tone should be preserved. This is checking the integrity, and then the tumor removal was done very carefully. After tumor removal, we need to check the cochlear and facial lobe integrity. After sealing IAC with soft tissue, electrode insertion was done. Then bone dust and cartilage reinforcements was done to prevent electrode extrusion. Similar situation with cochlear schwannoma. Cochlear schwannoma can be the best candidate for this infrapromontorial or the transpromontorial schwannoma removal plus simultaneously cochlear implantation. In cochlear schwannoma, sometimes we need to open mid-tone to remove the tumor. The surgical procedure was similar, but if the cochlear roof was open, we need to do the reinforcement with tragal cartilage and perichondrium. Last category for endoscopic transcanal approach is facial lobe schwannoma. A 49-year-old female with Hausbregmann grade 3 facial palsy with severe hearing loss patient want to get operation because she has preoperative facial palsy and very anxiety about the tumor and also the severe tinnitus. We can see the tumor in IAC and genital ganglion. Facial palsy and hearing loss in left side was shown. Tumor was confined to the internal canal and genital ganglion. Endoscopic tumor removal and nerve graft was performed. Similar with transpromontorial approach in bacillus schwannoma. Facial lobe demarcation was performed. His tympanic segment, genital ganglion, cochlea was opened. It's a modulus, and drilling a little bit more. Tympanic segment, modulus, labyrinth segment was demarcated. The tumor is here. Tumor was definitely connected with the labyrinthine segment in the intra-auditory canal segment. We remove the tumor, and then we can connect the IAC and the labyrinthine segment of the facial lobe using the sural lobe. We cannot suture this nerve, so just gluing is the only method for the nerve graft. After tumor removal and the sural lobe graft, you can see the post-operative facial lobe function. Facial lobe function is not so satisfied, but acceptable. Also recap for my series short operation time and better outcomes in minimal invasive concept. Till now, 27 patients was done by this approach. The indication is a tumor in CUS1 or CUS2, but mostly CUS1 tumor without hearing is feasible for this approach. Next, I'll touch the minimally invasive keyhole midcranial fossa approach. But sometimes, based on the tumor size, location, and hearing level, midcranial fossa approach is needed. If the tumor is located mainly in CPA and not in IAC, minimally invasive keyhole lateral sigmoid approach is best. Of course, we can use translab approach in that patient. If the tumor is confined intra-aortic canal in the right side patient, we can use endoscopic transcanal approach in that patient. But if hearing of this patient is good, we need to use hearing preservation method such as midcranial fossa approach. Midcranial fossa approach can spare hearing organ and directly access to the intra-aortic canal is ideal for IAC confined tumor with serviceable hearing. But classical method require big incision, excessive temporal muscle retraction, and large craniotomy. From 2014, several studies reported the feasibility of keyhole midcranial fossa approach for tegment repair of superior semicircular canal disease syndrome treatment. In cadaveric study, only 1 centimeter craniotomy and inserting endoscope provided them sufficient visualization of arcuate eminence. Superior semicircular canal disease could be managed using this 1 centimeter hole. After that, several clinical series reported their success in SSCCD treatment using keyhole midcranial fossa approach. I thought I could use this approach also in small vestibular schwannoma. Why not? Coincidentally, I encountered the patient who perfectly fit this approach. The young male with facial lobe schwannoma with cystic degeneration visited my clinic. The tumor size was rapidly increased by cystic degeneration, but cannot be totally removed because it was facial lobe schwannoma. Gamma knife surgery was also not an indication because of cystic character and the big size. So I decided to maximally decompress the tumor inside. The tumor could easily be accessed via minimally invasive midcranial fossa approach. You can see the surgical video, and the tumor was easily found in small incision and craniotomy. I ruptured tumor and sucked out of the fluid. In midcranial fossa approach, identification of internal audit canal is biggest hurdle because narrow and deep working space, and there are not definite surgical landmarks. Many masters introduced their own surgical tips to identify internal audit canal from 1960s, but still very difficult for beginners, and there is no royal way yet. Almost 20 years ago, my teacher reported also one method for IAC identification. He used zygomatic root and ossicles for landmark. The distance from zygomatic root to malleus is almost 2 centimeters, and the distance between malleus and superior semicircular canal was 8 millimeters. The distance between malleus and geniculate ganglion was 7 millimeters and 23 degrees behind. If we performed craniotomy to anterior to posterior, it can make midcranial fossa approach as a nightmare. So paradoxically, using surface landmark, small openings alleviate surgeons' confusion about craniotomy locations and force them to make a quick decision. So from those two previous concepts, first from several trials of keyhole midcranial fossa approach for SSCD, and second concept, my teacher's IAC identification method, I decided to try to do keyhole midcranial fossa approach for small vestibular schwannoma removal. In keyhole, MCFA for vestibular schwannoma removal is possible. Operation time is shorter than that of classical MCFA because speedy decision. And cosmesis is one of the most significant advantages of minimally invasive technique. For this, I performed cadaveric dissection for practice and testing feasibility. Then performed 6 cases of operations. Lastly, I compared surgical outcomes between new method and classical method. Let me show the result of this trial. First, cadaveric demonstrations. As described by many surgeons and my teacher, basic concept is using zygomatic root and ossicles. The IAC vertical crest was placed on the straight line connecting the zygomatic root and malleus head. First, finding zygomatic root, then explode ossicles 17.8 millimeter distance. Then try to find geniculate ganglion approximately 6.5 millimeter away at approximately 23rd degree anterior to the malleus head. After finding geniculate ganglion, the next steps are not so difficult. Labyrinthine segment of facial nerve and the fundus of IAC could be successfully traced. An endoscope could be used to reach the force of the IAC and secure the view. Under endoscope guidance, the porus of IAC was skeletonized close to the petrous ridge. For fresh adult cadaveric whole heads with 8 ears were used. 2.5 centimeter horizontal incision was made at the level of zygomatic root corresponding to tragal and superior helical level. You can see the incision's midpoint was perpendicular to the extension of the tragus. Subcutaneous tissue, temporalis muscle, and periosteum were dissected to expose the zygomatic root and the temporal bone. 2 centimeter diameter round keyhole craniotomy was performed centered on the midpoint of skin incision by drilling under the squamous suture line. The anatomical structure was explored. You can see the ossicles, geniculate ganglion, then identify the IAC. Because of the small working space, special shielded microdrill and higher resolution endoscopes were needed. During this procedure, the tegment tympani was opened to identify the malleus head and as a landmark, but we can put a part of cortical bone which was from keyhole craniotomy. Next, surgical case series. Most steps are similar as cadaveric demonstration and performed under microscope, as in the right panels. And also we need shielded microdrill in the left movie. This is also performed under microscope. But very inside and deeper portion, we need to use endoscope for confirming the status. After opening the IAC dura, we can remove part of tumor, then insert endoscope for checking the status and removing remnant tumor. For 10 months, I performed 6 small vestibular schwannoma patients using keyhole MCFA. Mostly we follow 50-50 rule except one patient, and gross total removal was achieved except one case. In relatively big tumor with total 11 millimeter size and 2 millimeter extended into the CPA is not so easy to remove gross totally. Lastly, clinical analysis for feasibility of keyhole MCFA. You can see the demographics in both keyhole MCFA and classical MCFA, and there are no difference in many factors. Surgical time is much shorter in keyhole MCFA because there is less labor for opening and closure. Also, quickening detecting of IAC is also one of the reasons in reducing the time. Hospital stay is also shorter in keyhole MCFA because of rapid recovery from less invasive surgeries. There is no method to objective comparing measurement for cosmesis, but you can see the difference about incision and muscle sunken rate. Hearing result. Red number is from keyhole MCFA and blue number is classical MCFA. Left panel shows preoperative hearing, and patient preoperative hearing correspond to 50-50 rule in yellow box. Two patient hearing are worse than 50-50 but acceptable indications. Right panel shows postoperative hearing and patient hearing are favorably preserved, which means less than 20 decibel, 20% worse in green box. 1/3 of keyhole MCFA and half of classical MCFA preserved patient hearing and showed no statistical difference. The conclusion is that the endoscopic assisted keyhole midcranial fossa approach to internal auditory canal is feasible in cadaveric model clinical situation and superior to classical midcranial fossa approach in surgical time, hospital stay, superior to cosmetic aspect. Thank you for your attention.
Thank you, Prof. Moon. Maybe before the discussion, we would like to hear one more presentation, and then afterwards we are going to do the question and answer session. Untuk topik yang ketiga, saya persilahkan kepada Dr. Diana Rosalina untuk memberikan topik mengenai basic to advanced EES. Mungkin tadi kita sudah membahas yang basic, juga sudah membahas yang advance. Kemudian kita sedang perlu menarik benang merahnya mungkin Dr. Diana. Silakan, Dokter.
Oke, Assalamualaikum warahmatullahi wabarakatuh. Jadi ini step yang dasar yang harus kita kuasai adalah kita evaluasi ear canal, infiltrasi telinga, dan ini adalah step yang nomor 1 harus kita terus belajar tympanomeatal flap insisi. Kalau ini nggak lewat, kita nggak akan bisa lewat untuk step-step selanjutnya. Kemudian kita mengelevasi tympanomeatal flap ini dari ear canal dan anulus, kemudian kita juga harus melepaskan dari malleus. Kemudian kita harus bisa mengidentifikasi retro, hipo, meso, protimpanum dengan sangat baik semua detail yang tadi sudah dijelaskan Dr. Angga. Kemudian ini adalah juga yang selanjutnya menjadi kuncinya middle ear disease, yaitu isthmus tympani, ossicle facial nerve. Dan selanjutnya adalah kita harus menguasai atikotomi, atikoantrostomi. Kalau tadi yang kita dijelaskan seperti Prof. Insekmun, tentunya kita harus lebih lanjut menguasai anatomi koklea, anatomi skull base, hingga akhirnya kita bisa mengaplikasikan endoskopi pada step-step selanjutnya. Nah, di real operasi, kita akan berhadapan dengan darah, patologi. Setiap patologi punya ciri khas, kemudian ada untuk middle ear, pastinya yang menjadi momok adalah kita akan berhadapan dengan ossicle dan facial nerve. Training model harus kita lakukan dan gold standarnya cadaver disseksi, seperti tadi juga Prof. Insekmun juga melakukan itu pada untuk skull base beliau. Dan untuk kita alternatif lain untuk kita di tahap awal bisa menggunakan domba ya, bahkan di sini dicontohkan melakukan miringoplasti, ossicopoloplasti ya, atau menggunakan kaprin, tapi katanya ini lebih sulit ya menggunakan kambing, jadi pilihan utama adalah domba. Dan di India ada menggunakan untuk dexterity menggunakan batang pepaya untuk melepaskan latihan tympanomeatal flap. Mungkin ini bisa kita coba untuk di residen seperti itu. Kemudian untuk learning curve dalam endoscopic surgery, miringoplasti merupakan tindakan pertama yang harus kita mulai. Tanpa memulai miringoplasti tidak ada step-step operasi selanjutnya. Dan banyak penelitian mengukur bagaimana sih learning curve dalam ES ini dari lama operasi, dari kesuksesan operasi berdasarkan graph intake, terus perbaikan audiometri, terus berapa rate dari konversi ke mikroskop, dan juga ada rate komplikasi. Banyak sudah mulai banyak ya laporan tentang learning curve bagaimana di ES ini, dan dari rata-rata dari tahun 2017 sampai 2021 ini rata-rata berada di angka 50, 60, 100. Jadi untuk ini untuk timpanoplasti tipe 1 dan stapes rata-rata di sekian di 50 60 kasus untuk mencapai steady line dalam learning curve. Dan ini ada suatu penelitian, ada sebenarnya kita harus apakah mikroskop akan mempengaruhi kurva belajar kita, dan ini menarik mengcompare dua kelompok dengan orang dengan latar belakang mikroskop dan tanpa latar belakang mikroskop. Ternyata ada 5 operasi pertama dari orang-orang yang mempunyai latar belakang mikroskop justru diawali dengan lebih lama. Mungkin karena mereka di analisanya adalah mereka sudah sangat nyaman dengan mikroskop sehingga kemudian merasa lebih relaktan terhadap memulai endoskop. Tapi kemudian kelompok mikroskop ini karena sudah menguasai anatomi, mereka mempunyai percepatan yang lebih tinggi hingga mereka menyamai status akhirnya kelompok yang tanpa pengalaman mikroskop kecepatannya lebih cepat sesudah dia 5 kasus, maka lebih cepat yang mikroskop. Tapi sama-sama dua kelompok itu akan mencapai suatu proses yang mencapai yang baik dua-duanya. Dan dalam penelitian ini juga ditanyakan apa sih yang paling momok dari kita memulai endoscopic ear surgery. Jadi yang pertama, yang nomor 1 adalah bleeding control. Jadi bleeding management adalah sesuatu yang harus selalu kita latih karena ini memang momok pertama dan tadi sudah dijelaskan juga bagaimana kita memanage bleeding ya, banyak step-stepnya hingga kita harus menguasainya untuk kita menghilangkan momok pertama ini. Dan ada juga penelitian membandingkan juga 2 kelompok ini antara endoskopi dengan mikroskop. Nah ini kita lihat grafiknya ternyata dan di sini kelompok yang memang punya pengalaman mikroskop memang lebih cepat, di sini malah kebalikannya dia lebih cepat, tapi sesudah 5 kasus 6 kasus maka kita lihat sama ya. Jadi dari penelitian ini ternyata menunjukkan bahwa kita nggak harus memulai dulu dengan mikroskop. Jadi kita bisa sama-sama memulai mikroskop dan endoskop bisa sama-sama dimulai dan tidak diharuskan untuk harus menguasai mikroskop dulu baru endoskop. Tapi yang penting adalah karena ini adalah suatu kurva belajar yang berbeda sebenarnya. Jadi kalau kita bisa melakukan bersamaan itu adalah yang disarankan yaitu parallel learning for both technique, not sequence technique. Ini 3 hal yang penting ya, bagaimana kita tadi sudah saya utarakan untuk mempersiapkan operasi. Dan di sini saya coba merangkum apa sih lingkaran yang harus kita kuasai. Pertama kita harus tahu dulu level kompetensi kita, kemudian kita harus tahu fasilitas yang kita miliki, kita harus mampu menseleksi kasus, dan kemudian kita membuat keputusan operasi apa dari kasus yang kita pilih tersebut. Nah, di level kompetensi ini saya mengutip dari jurnal yang dari Dr. Phil Prajan dan Prof. Pageran. Di sini adalah level 1 sampai level 5. Level 1 adalah diagnostik ya, beginner sekali. Nah, tapi kita harus mulai dari level 2 ini. Kita harus loncat ke level 2 untuk kita sampai ke level 5. Dan di sini utamakan mulai dengan miringoplasti ya. Kemudian di level 3 ini adalah di level 2 kasus-kasus yang tidak memerlukan eksplorasi cavum tympani, di level 3 sudah ada eksplorasi cavum tympani, level 4 sudah cholesteatoma middle ear, dan level 5 sudah seperti Prof. Insekmun di inner ear dan skull base. Dan kita lihat di sini mikroskop menjadi tidak bisa ditinggalkan ya. Jadi harus sejajar kompetensi antara endoskop dan mikroskop hingga kita berjalan terus mencapai peningkatan kompetensi. Nah kita kemudian tadi level sudah, sekarang fasilitas. Ini yang terjadi di Indonesia. Kita punya sistem rujukan ABC dan kita tahu di tipe C mungkin sekarang adalah mikroskop yang tidak ada kebanyakan, tapi endoskop ada. Nah, kemudian umumnya di semua rumah sakit tipe A, B, C punya endoskop, tapi mikroskop nggak semuanya punya. Nah, kemudian apakah yang tipe C endoskop ini semua kasus endoskopik ear surgery bisa dikerjakan? Nah, ini juga tergantung dari bagaimana fasilitasnya lengkap atau tidak untuk instrumennya dan juga bagaimana kompetensinya tadi ternyata untuk menaikkan level-level tersebut tidak bisa hanya dengan kompetensi endoskop saja. Jadi dua-duanya harus berjalan kalau kita ingin meningkatkan semua kompetensi itu. Nah ini standarnya tadi sudah dijelaskan ya, yang standar sudah pasti harus ada endoskop, HD, light source ya, ini semua harus minimal standar sudah jelas ya, kita jangan sampai tidak pakai HD. Kemudian kita ini, tadi yang saya sudah singgung sedikit adalah segala suatu instrumen yang curve. Tanpa instrumen di sini kita lihat ya semuanya curve, ada curve atas, bawah, kanan, kiri. Nah ini belokan-belokan ini sangat spesifik sekali tempatnya di sini untuk sinus timpani, ada untuk timpani, ada untuk atik. dan juga saksen-saksennya juga sangat spesial. Dan ini yang tadi juga disinggung oleh Dr. Philip tentang Panet set. Ya, Panet ini sangat-sangat membantu sekali ya. Jadi beberapa yang belok curve-curve ini punya tujuannya. Dan kita pun harus berlatih terus dengan menggunakan alat-alat ini sehingga kita menjadi nyaman untuk bekerja di tempat tertentu. Nah, kemudian bone dissection kita bisa dengan kuret ya, seperti ini membuka atik. Ini adalah suatu step yang paling awal membuka bone sebenarnya. Jadi dengan kuret, dengan sisal ya, ini sisal dan tidak semua sisal yang kita rekomendasikan. Di sini salah satunya yang direkomendasikan adalah Yamagata sisal, yang ini memang produk khusus untuk endoscopic ear surgery dengan berbagai ukuran ya. Biasanya Prof. Seji senang sekali menggunakan ini dan tulangnya bisa utuh keluar sehingga kita bisa rekonstruksi lagi dengan tulang tersebut. Itu yang menariknya, bisa dengan sangat rapih karena ukurannya juga banyak sekali kalau kita lihat. Kemudian nah, tadi bor juga tetap digunakan, walaupun tadi ada bor straight bor, tapi juga endoskopik ada yang khusus dengan curve bor, jadi mata bornya yang lengkung ya seperti ini, dan tadi juga ada kriteria bagaimana kecepatannya, tidak menggunakan air ya di sini. Dan memang masalahnya menjadi ada bone dust ya, jadi seperti itu. Jadi kita agak harus sabar. Nah, ini yang paling nyaman sebenarnya yang disebut piezo surgery atau menggunakan ultrasonic vibration instrument. Nah, di sini sebenarnya ini suatu alat yang lama, sudah dipakai di bidang lain ya, di ortopedi seperti itu atau gigi. Nah, ini sudah ada alat yang khusus untuk ke telinga, dan ini sangat enak sekali bisa membuang tulang tanpa merusak jaringan lunak. Jadi kalau kita ingin sampai seperti Prof. Insekmun, sampai cochlea, skull base ya, kita mungkin memang harus dilengkapi alat-alat seperti ini nantinya. Nah, ini suatu step yang sangat penting ya, atikotomi. Untuk kita yang bergelut dengan otitis media, daerah sinilah kuncinya penyakit. Jadi kita buka daerah sini dengan atikotomi dan inilah yang akan kita paparkan. Jadi kita harus sangat friendly dengan daerah sini dalam operasi. Ini kita sama. Ini contoh tadi menggunakan sisal. Ya. Nah, ini adalah dua anatomi yang menjadi perhatian kita, facial nerve, ossicle. Dua-duanya nggak pengen kita injury. Jadi kuncinya kita step naik selanjutnya sesudah kita bisa mengerjakan miringoplasi adalah kita bisa bekerja di daerah atik. Jadi daerah atik ini kita harus menguasai, bisa membuka atik dengan baik, kita harus atikotomi, membuka skutum dengan baik, dan kita harus bisa memaparkan daerah isthmus timpani, kemudian ossicle chain, ini kita bisa identifikasi, udostapedial joint, facial nerve, head of malleus, ini semua kita bisa lihat. Dan perlu diingat bahwa sampai hampir 30% tympanic part of the facial nerve itu dehiscent. Jadi bukannya kita nggak bisa mencederai juga. Jadi kita harus bisa mengidentifikasi dengan landmark-landmark yang berada di sekitarnya di mana mulainya facialis. Jadi di sini seperti ini kita harus ketemu dulu KSS lateral, kita harus ketemu piramidal eminence, maka facialis berada di tengahnya, processus cochlearis, ini semua harus kita temukan sehingga kita akan pasti ketemu di mana area dari facial nerve. Nah, ketiga case selection. Nah, pilihlah kasus dari central perforation ya, jangan loncat langsung ke facial nerve involvement. Nah, untuk itu kita harus preoperatif dengan baik, melibatkan atau enggak sih? Nah, pilih yang central perforation, terus yang baru kita meningkat ke subtotal, melibatkan mucosa tympanic cavity, kemudian yang melibatkan lanjut ke yang melibatkan ossicle, kemudian kita melibatkan ventilasi root, atik, antrum, kemudian baru mulai kasus-kasus kolesteatoma karena tuntutannya memang harus sangat bersih, atur, kemudian kita berlanjut ke facial nerve dan middle ear, bahkan selanjutnya bisa ke arah skull base. Nah, ini tadi preoperative assessment. Nah, ini ada 3 hal yang penting dari seleksi kasus ya. Ada preoperative clinical assessment, hearing status, dan CT scan. 3 hal ini selalu harus kita input dalam suatu preoperatif assessment kita. Nah, jadi kalau misalnya kita mengenali, ini yang saya bilang tadi, kita kenali jangan pakai lampu kepala aja. Dan kemudian ketika kita kenali, kita dengan endoskopi atau mikroskop, kenali dengan sangat detail. Jadi bukan hanya, oh ini perforasi atik, tapi kita lihat dia nempel di mana, apa yang tersisa, seperti ini. Kita sudah lihat, dan di sini ini di atik terbuka ya, kita masih mengenali head of malleus, Jadi malleus masih ada, placenza masih ada. Nah, seperti ini juga kasusnya kita bisa kenali masanya di mana, di liang telinga menutup, granulasi, kemudian membran timpani tidak kelihatan, dan ini juga perforasi. Memang kita ngeliatnya perforasi aja, tapi kita harus mengenali kayak gini mukosanya, inflamasi. Ini akan memberikan kita prediksi bahwa ada gangguan ventilasi root seperti itu. Jadi kita akan mungkin beri kasus yang akan inflamasi sendiri, kita akan berdil dengan darah lebih banyak dibandingkan kasus-kasus yang kering. Atau juga di daerah tumor liang telinga, kita juga bisa mengakses sampai genang telinga ke belakangnya. Di sini kita lihat, jadi kita bisa melokalisir. Intinya kita bisa melokalisir patologi itu ada di mana. Nah, terus dalam preoperatif assessment ini kita juga menegakkan diagnosis. Dengan diagnosis yang misalnya contohnya kayak OMSK tipe aman. Ini di kompetensi level 2. Kalau dia aktif artinya naik dia level 3. Kalau kolesterolma dia level 4 ya. Demikian selanjutnya. Jadi kita tahu ini saya di kasus di mana memulainya. Kemudian evaluasi kanalnya dengan baik. Bisa nggak sih kita kerja endoskopik instrumen bersamaan? Itu syarat utama melakukan endoskopi. Kalau dua-dua alat tersebut tidak bisa bekerja, udah pasti tidak indikasi untuk endoskopi. Jadi kita harus mencobai dulu preoperatif, ear kanalnya adekuat untuk EES bekerja, instrumen dengan endoskop. Dan kemudian audiometri ini atau speech audiometri itu penyimpulan yang sangat juga penting untuk tadi bisa menyimpulkan nih terlibat gak sih osikel. Ada banyak sekali penelitian ya yang menghubungkan antara hasil dari pemeriksaan pendengaran ini dengan temuan operasi. Jadi dengan kita melakukan pemeriksaan pendengaran dengan sangat baik, kita diskusi dengan ahlinya juga, maka kita bisa memprediksi ini, oh ini kasusnya bisa saja perforasinya seolah-olah sentral kecil, tapi audiogramnya 60 desibel. Jangan seneng dulu, oh ini miringoplasti aja. Belum tentu. Jadi kita harus siap untuk, oh ini kasus saya atau bukan, gitu, untuk kita melanjutkan step kompetensi kita. Nah ini adalah contoh di mana CT scan ya yang tadi penting. Kita dari CT scan yang bersih seperti ini kita bisa melihat rangkaian osikel, kemudian bersih di atik. Nah nanti ini yang akan kita temukan seperti ini. Nah kalau dia seperti ini, nggak ada alasan kita untuk membuka atik, membuka mastoid, dan tidak ada yang harus kita kutak-kutik dari osikel. Jadi kalau dia pada kasus ini misalnya perforasi, ya cukup perforasi saja yang kita perbaiki. Jadi di situ kita, oh pekerjaan saya ternyata cuma sampai di timpanik timpanoplasti gitu. Jadi kita akan belajar akan mempraktekannya dengan step by step. Dan ini juga contohnya. Jadi pada kasus perforasinya sentral, kemudian semuanya bersih, mastoid bersih, atik bersih. Nggak ada alasan kita untuk buka mastoid, nggak ada alasan kita untuk ngatak-ngatik osikel. Apalagi kalau misalnya memang audiometrinya nanti ternyata ringan ya seperti itu. Ini juga kita bisa merekonstruksi ya posisi liang telinga. Kemudian ini level yang selanjutnya, dia melibatkan di sini nih, seperti tadi osikel di medialnya ada perselubungan. Jadi ini dalam kasus seperti ini kita tahu akan melibatkan, kita mungkin harus membuang inkus seperti itu. Kita buka dulu inkusnya, dan di sini patologinya meluas, sklerotik, dan ini apakah menjadi indikasi untuk hanya ES. Nah, kemudian kita putuskan ya seperti ini keputusan kita dari 3 option tadi, contohnya dari klinis, audiometri, audiometri kita bisa bilang, oh ini cuma cukup miringoplasti, seperti itu. Atau kita di level 3, kita lihat, oh konduksinya cukup berat, ada perselubungan di atik, kemudian kita lihat, dan ternyata benar, ya kan terlibat di sini penuh. Jadi kalau kita ketemu kasus yang seperti ini, ya kita harus berlatih untuk mampu melakukan tindakan dengan aman di daerah isthmus. Sehingga ketika kita naik ke level 3, kita tidak hanya membuka aja, tapi kita harus bisa bersihin patologinya dari osikel, facial nerve dengan aman, kemudian kita memperbaiki ventilasi root, habis udah kita bongkar, kita harus bisa merekonstruksinya, apakah osikelnya, skutumnya, timpanik membrannya, dan kita harus siap mikroskop. Karena kalau ada apa-apa, kita misalnya bleeding problem seperti itu, dan kita tidak mampu menggunakan satu tangan, jangan malu-malu untuk kembali ke mikroskop. Nah ini kemudian ini salah satu contoh bagaimana melakukan osikoplasi yang paling sederhana dengan inkus interposition. Kalau kita harus membukanya tadi, mengeluarkannya kita harus merekonstruksinya. Ini suatu prinsip yang diajarkan bagaimana kita membuat inkus interposition, kita buang bagian long processusnya, kemudian kita bentuk seperti ini dan kita tempelkan. Nah ini contohnya. Di sini kita lihat ada diskusi, kemudian ada isthmus problem ya, sehingga saya putuskan untuk diangkat aja karena pembersihannya juga sulit dan memang pendengaran juga sudah relatif sedang berat. Cuman konsekuensinya kita keluarin dulu, kita akan bisa mampu membersihkan isthmus dengan baik. Namun kita harus bisa merekonstruksinya sesudah kita keluarin. Dan di sini target nomor 1 ventilasi pasti lebih tercapai dan lebih aman. Ya, kemudian sesudah kita keluarkan, maka kita bentuk infus tadi menjadi penghubung kembali sehingga sesudah daerah ventilasinya membaik, maka kita pasang di suprastapes seperti ini sehingga pendengaran bisa lebih baik. Jadi kita sekarang ini kita sudah harus punya visi mengoperasi telinga itu bagaimana caranya pasien menjadi lebih baik pendengarannya. Baru kemudian kita rekonstruksi gendang telinganya dan juga daerah skutumnya. Nah ini contoh yang kasus kolesteatom ya. Dan kita juga bisa memprediksi daerah sapes, ini isthmus timpani. Isthmus timpani penuh ya, kemudian kita sudah tahu akan ada masalah di isthmus timpani, di facial nerve seperti ini. Jadi kita sudah siap nih harus bekerja di dekat facial nerve. Nah ini di kasus kolesteatom kita harus, ini contohnya kita harus membuang matriks dari round window ya. Dengan sangat hati-hati jangan sampai robek ya. Tapi ini endoskopi akan sangat melihat ini dengan lebih mudah, lebih jelas. Sehingga kita juga makin yakin untuk membersihkan patologi ya dengan baik dan lebih aman. Di sini foramen ovale dan kita pastikan gerakannya baik ya. Jadi tidak ada yang bocor. Nah, ini juga suatu contoh ya di mana melibatkan facial nerve ya. Di sini matrik melibatkan foramen ovale dan lihat di sini nervus 7-nya terbuka. Seperti ini. Dan kita harus membuang matriksnya dengan sangat aman ya, lakukan sejajar, selalu lakukan sejajar anatomi dengan patologi. Jadi jangan tegak lurus ya. Jadi lakukan dan gunakan alat yang setajam mungkin. Tapi yang nomor 1 adalah kita melihat dengan baik. Segala sesuatu yang bisa dilihat dengan baik dan kita tahu cara diseksinya, insya Allah kita bisa melakukan operasi dengan sangat aman. Oke, nah jadi kesimpulannya untuk kita mampu mengembangkan ES dari basic sampai advance, maka kita nomor 1 kita harus latihan di model, anatomi. Kemudian selalu kita mulai dari miringoplasti dan kita pilih kasus untuk step by step. Kita harus friendly untuk bekerja bersama ossicle, facial nerve, dan ventilation route. Dan kenali level kompetensi kita, lengkapi fasilitas kita, ya, dan terus kembangkan level dan fasilitas tersebut. Dan kita harus sangat kritis untuk memilih pasien dan rutin praktis IES. Jadi minimal harus mencapai, memang secara literatur mencapai 50 kasus untuk mendapatkan steady state dari learning curve. Dan yang terakhir ini mungkin kata-kata klise, tapi memang ini selalu terngiang kalau kita udah mau nyerah. Dan ini saya ingat selalu dari kata-kata dari Prof. Zainul, don't give up. So, jadi kalau kita emang mau terus di operasi telinga ini memang kita tidak bisa don't give up dan kita terus belajar dan mempraktekannya. Terima kasih.
Baik, terima kasih Dr. Diana. Mungkin jangan meninggalkan panggung dulu karena setelah ini kita akan sesi diskusi. Saya persilakan Dr. Diana, kemudian juga Dr. Philip to come back to the stage and we will proceed with the discussion. And also I would like to welcome also Prof. Moon from Korea to also join the panel for the discussion. Baik, ya. Untuk pertanyaan yang pertama mungkin dari peserta online di Zoom chatroom, pertanyaannya untuk Dr. Philip Rajan. Dr. Philip, pada umumnya cochlear implant dilakukan dengan mikroskop. Bagaimana kriteria pasien yang dapat dilakukan dengan atau maybe assisted with endoscope, Dr. Philip? Kriteria the patient criteria for endoscopic assisted cochlear implantation.
Okay, seperti dalam bicara saya tadi, kita menggunakan endoskop untuk dua situasi. Satu, bila ada anomali pada telinga tengah. So, kalau ada congenital malformations, untuk cari di tempat mana round window, kita menggunakan endoskop. Situasi kedua di mana saya menggunakan ialah di mana saya tak tentu. Saya memang buat cara mikroskop. Tapi tiba-tiba bila buat posterior tympanotomy, saya telah hilang saya punya hala tuju. So saya tidak tentu lagi dengan anatomi saya. So dalam hal itu saya menggunakan endoskop untuk melihat anatomi middle ear atau anatomi telinga tengah. So bila saya dapat gambaran yang lebih jelas tentang anatomi telinga tengah, saya dapat menentukan di mana saya hendak tebuk lubang untuk membuat cochleostomy, baru saya menggunakan balik mikroskop untuk membuat operation. So bagi saya ada dua saja indikasi. Satu, bila you sudah hilang atau saya sudah hilang I punya anatomi, saya menentukan anatomi yang betul. Yang kedua adalah dengan kes-kes yang ada anatomi yang luar biasa ataupun abnormal anatomy seperti congenital anatomy atau malformation. Itu saja bagi saya lah indikasi.
Okay. Oh, so maybe follow-up question, Dr. Philip. How about condition with very sclerotic temporal bone and maybe with aplasia or hypoplasia of the antrum? So it's rather difficult to do a posterior tympanotomy. Do you suggest also with the endoscopic assisted or the classical subtotal petrosectomy and also with the blind side closure?
So dalam kes itu sama seperti cochlear implant dalam kes-kes cholesteatoma. So dalam cholesteatoma pun kita buat canal wall down and then kita buat blind side closure. So dalam kes-kes itu pun saya rasa dengan sclerotic mastoid prinsip adalah sama macam cholesteatoma. Cochlear implant dalam cholesteatoma. So mungkin kita terpaksa buat satu macam eticoenterostomy, macam canal wall down procedure untuk mendapat visualization yang lebih baik, lebih jelas, baru kita buat cochlear implant dan kita perlu tutup. So sama ada nak buat blind side closure ataupun dengan multi-layered closure, I think itu terpulang. So I think kalau kita nampak Prof Im Segmon punya presentation pun untuk yang trans cochlear punya operation, dia tidak membuat full blind side closure, dia buat partial closure. Saya rasa kalau memang dah cukup ada bone multi-layer closure yang cukup tebal, tak perlu buat full blind side. Tapi itu adalah terpulang pada pakar sendirilah.
Okay, baik. Terima kasih Dr. Philip. So the second question is for Prof. Moon. So this is a question from the participant in the online chat room. So Professor Moon, during the surgery, as an ENT surgeon, can we perform the surgery like your skull-based surgery in your presentation? Is it possible to do alone only as an ENT surgeon, or do we need to join operation with the neurosurgeon? So what do you think, Prof. Moon?
It depends on surgeon's experience and surgeon's preference. For me, I do by myself. So in most cases, I do the tumor dissection and tumor removal by myself. But I think if you are the beginner, you can collaborate with a neurosurgeon in your starting. But after you have experience, you can be an independent for the tumor dissection also. Yeah, it's up to your preference.
Okay, so thank you, Prof. Moon. And a follow-up question maybe on that, Prof. Moon. So do you have experience in doing the translabyrinth approach, combined approach between the microscope and endoscope in a translabyrinth? Because you mentioned about the fossa media approach in your presentation. And how about the translab approach?
Yes. Nowadays, I use the endoscope for also use the endoscope for the translab. But in the translab approaching, the surgical view and the working space is quite enough. So just checking in the last step, I only use the endoscope because translab is a very is a quite enough view. So you can use a microscope and two hand surgery. But in the last part, in the very deep portion or some kind of very in the angled portion, endoscope can be useful. Just checking.
Ya, Oke, thank you, Prof. Moon. Apakah ada pertanyaan lagi dari peserta mungkin yang hadir offline dari studio 1, 2, 3 atau mungkin dari Stellar? Apakah ada pertanyaan? Belum. Kalau misalnya tidak ada pertanyaan, mungkin saya ada satu pertanyaan untuk Dr. Diana. Tadi sebenarnya ini pertanyaan dari peserta yang online, tapi mungkin di sesi sebelumnya belum sempat tertanyakan, tapi bisa kita tanyakan pada sesi ini juga. Jadi tadi ada pertanyaan mengenai alat ya Dr. Diana. Tadi Dr. Diana menyampaikan bahwa jangan ragu untuk kalau misalnya kita harus menggunakan mikroskop gitu ya, kita harus kembali ke mikroskop pada saat intraoperatif. Tadi saya ada satu pertanyaan di sesi yang sebelumnya di chatroom bahwa kebanyakan seperti Dr. Alin juga sampaikan banyak rumah sakit di tipe C yang tidak memiliki mikroskop tapi punya endoskop gitu ya Dok. Nah, bagaimana dengan kasus-kasus kondisi seperti itu? Karena kita tahu bahwa suatu waktu kita perlu kembali ke mikroskop intraoperatif. Nah, bagaimana menurut Dr. Alin, apakah jadi tetap boleh melakukan endoscopic ear surgery atau bagaimana modifikasi yang harus dilakukan, Dok?
Oke. Jadi kalau kita hanya punya endoskop, ya, jadi tindakan yang hanya bisa dilakukan itu adalah miringoplastik. Dan untuk tahu itu memang miringoplastik, kita tahu sudah di-assess. Ini memang masalahnya hanya perforasi sentral, kemudian tidak ada keterlibatan mukosa di tympanic cavity, tidak ada keterlibatan mukosa keterlibatan di isthmus timpani. Nah, jadi tampilannya perforasi sentral, mukosa baik, audiometri ringan, ya. Kalau kita CT scan bersih. Nah, kasus seperti itu kalau kita sudah tertrain endoskopi, harusnya bisa dikerjakan transkanal, aman, ya. Tapi kalau sudah melibatkan isthmus, kemudian kita jelas harus bekerja dengan bahkan dengan 30 derajat. Nah, jadi di situ sudah harus ada mengantisipasi kiranya ada namanya 15 minutes rule. Jadi di saat kita dalam proses kita meningkatkan kompetensi, ternyata wah kita susah berdealing dengan darah di daerah isthmus, di daerah antromastoid. Lebih dari 15 menit kita rubah ke mastoid. Itu di awal-awal kita belajar. Jadi itulah posisi di mana pasien itu penyakitnya memang kita tahu melibatkan situ, kita nggak akan bertambah. Jadi kalau kita cuma belajar endoskopi dan punya fasilitas endoskopi saja, jelas kompetensi kita nggak akan naik. Karena kita tidak, jadi dalam penelitian yang sudah tadi saya jelaskan itu, jadi itu adalah suatu penelitian yang di awal dia belajar. Jadi di awal ya bisa orang sampai mencapai timpanoplasti tipe 1. Tapi selanjutnya ketika dia harus meningkat timpanoplasti tipe 2, tipe 3, kemudian dia harus berdeal dengan patologi, dia harus punya konsep yang benar tentang anatomi, transkanal, dan juga mikroskop. Seperti itu.
Ya, berarti bukannya tidak boleh melakukan IIS, tapi harus dimodifikasi kasus-kasus yang
betul.
akan
Jadi
dihadapi.
pilihan kasus itu yang harus benar ketika kita memang memilah-milah. Jadi kalau misalnya yang udah pasti, yang sering tertipu itu adalah kita seolah-olah melihat perforasinya kecil, tapi hati-hati pas ngelihat hanya dari dua pemeriksaan aja, misalnya gambaran genang telinga dan audiometri. Itu aja kita jangan tertipu dengan perforasi. Kita bisa, kalau audiometri ya benar, itu kita bisa curiga pada kasus-kasus yang gapnya lebih dari 30, itu kemungkinan osikel terlibat seperti itu.
Ya, jadi penting sekali ya dok untuk kita bisa melakukan preoperatif assessment tadi,
Betul.
baik dari pemeriksaan fisik, hasil pemeriksaan audiologi juga dan juga radiologi. Nanti
Yes.
mungkin kita akan banyak bahas pada saat sesi panel discussion ya dok ya, bagaimana pentingnya melakukan preoperatif dan apa yang nanti ditemukan pada saat intraoperatif. Mungkin karena keterbatasan waktu, maybe because of the time, Prof. Moon, I would like to conclude this session. So thank you for your participation in this session, Prof. Moon, and also Dr. Philip, and also Dr. Diana. Thank you, and we will continue with the next session with the panel discussion. With this, I close this session. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Ya, terima kasih dokter, para moderator dan narasumber. Dimohon untuk tetap di atas panggung dokter karena kita akan melakukan sesi dokumentasi.
Dr. Moon, would you please stay on screen as well? Because we're going to take a photo on the stage with you in it as well with the other speakers. Thank you. We are going to enter the last sessions of the day, the fourth sessions. We would like to tell all the participants who's attending the event offline that they can get coffee and snacks outside and bring it inside and continue with the session.
Ya, selamat datang kembali di The Third Jakarta Endoscopic Ear and Sinus Surgery Course. Selanjutnya, kita akan memasuki sesi terakhir di hari pertama rangkaian JE2S 2023. Sesi terakhir ini akan dimoderatori oleh Dr. Diana Rosalina, spesialis telinga hidung tenggorok bedah kepala leher, subspesialis otologi konsultan. Dr. Diana merupakan staf otologi di Rumah Sakit Fatmawati. Dapat disaksikan pada layar CV singkat dari Dr. Diana.
Welcome back to the third Jakarta Endoscopic Ear and Sinus Surgery course. Without further ado, we will begin the next session, moderated by Diana Rosalina, MD, ORL HNS. Dr. Diana is a medical staff of Pathology Division in Fatmawati General Hospital. On the screen, we can see the brief CV of Dr. Diana.
Kepada Dr. Diana, waktu dan tempat kami persilahkan.
Assalamualaikum warahmatullahi wabarakatuh. Good evening, everyone. And we come to the last session of today. And we will have a discussion of some cases, and I hope it will help all the participants and we can learn many things from the discussion. And we will have 3 panelists. The first one is Prof. Insekmun. I would like to say hello to Prof. Insekmun. Welcome, Prof. Insekmun. And Professor McMurray is very famous neurologist from the Yonsei University in South Korea, and he has a lot of experience in the AS, and especially until a skull-based surgeon. And he is a very good teacher and instructor, and I have experience with him also in a workshop of the skull-based. It's a great honor to be here, and welcome to the last session, Prof. Insekmun. And the second one is Dr. Philip Rajan. I invite again Dr. Philip Rajan to be a panelist in this session, and please come forward. And the third one is Dr. Harim Priyono, and please come forward also, and we will discuss the cases for today. So we prepare some cases that is from us here in Indonesia. It is mostly face this kind of problem, and maybe participant will be useful in this kind of case. And I hope all panelists can give your opinion and from your experience and your knowledge about this kind of case. So we try. So I present directly 3 kind of cases. Case number 1, number 2, and number 3. And we see that all the identity is female adult, all of them female adult, with a history of intermittent ear discharge more than in a years, and recurrently happen. But for case 1 and case 2 now is dry. And in case 3, it's more frequently ear discharge. And we can see from the physical examination, there is in the case number 1, there is a perforation in pars tensa with a little bit of tympanosclerosis, and we see the mucosa dry, mucosa in tympanic cavity is dry. In the second case, there also a perforation in pars tensa, and we can see tympanosclerosis in many parts of the tympanic membrane. And in the third case, we see the subtotal perforation of pars tympanic and pars tensa of tympanic membrane, and we see there is a destruction of the handle of malleus. And there is no pathology from this physical examination. We do not see any problem in the pars flaccida area. And then we go to the functional of the hearing. So for the case number 1, there is a conductive hearing loss in a mild 27 dB and with a partial eustachian tube dysfunction, and there is no problem with the left side. In the case number 2, the hearing function is conductive hearing loss about 37 dB, and in case number 3, there is a conductive hearing loss about 45 degree. And there is a history of the surgery in the right side with the post-tympanoplasty type 3. And now the hearing level is about 37 dB conductive. Until this data, is there any data that you want to be comment? Maybe Dr. Harim?
Yes, thank you, Dr. Diana. For case number 1, we can see that the conductive hearing loss is 27 decibel. It means the overall hearing level. And on the second, 37, and the last about 45 decibel. But actually, we need to know the level of bone conduction and also air conduction and bone gaps. Because from that information, we can predict the condition of the middle ear and also the mobility of the ossicle. For example, on the right, on the case number 1 with 27 decibel, it means a mild conductive hearing loss. Is probably with the result from the endoscopic photograph, we can see that only a small perforation, about 10% maybe, with a clean middle ear mucosa and normal without thickening of the mucosa. But we can see some sclerosis on the tympanic membrane. It means that this patient has a long history of middle ear ventilation problem. Maybe we can ask, is there any comorbid such as allergic rhinitis for this patient? And also, with this condition, with the result of ETF2 function from the tympanogram show a partial obstruction, but that measurement was done once at that time, but we cannot sure about the long-term or actual function of the ventilation tube. What I mean, with this small perforation, probably if we close that perforation, this patient may develop into otitis media with effusion after that.
Oh, okay.
Okay, so yeah, maybe I will offer we can close that. And also we consider if we close that perforation, maybe we can just add, or this patient may improve the hearing for 2 or 3, 5 decibels. But if that will be a developed effusion after that, it will be another problem.
Okay.
because we have to ask the patient for grommet tube insertion.
Hmm.
Once about several years ago, Prof. Lowong Kian from Singapore asked to me, Dr. Harim, if I have a small perforation, if you have a small perforation about 1 millimeters, will you close that perforation? I said no.
Hmm.
And yes, he agree because not always all those perforation is a bad
Hmm.
situation. Maybe it is a ventilation route
Okay.
because of the extension tube dysfunction. But on the case number 2, number 3, I will more confident to do tympanoplasty to close the perforation.
What is
Yeah.
the reason you are more confident for the case number 2 and number 3?
The perforation for case number 2 about 30%.
Hmm.
30% is it is like the size that we can close for because it is significantly cause hearing loss, conductive hearing loss, and as well for the case number 3, it's very obvious with long handle malleus erosion.
Case number 3.
Case number 3. Okay.
Okay, so it is very important to seek an analysis more about the background of the allergic, maybe in a problem with the eustachian tube, so we can give the prognosis better for the patient. That's
And on case number 2, we can see the pars flaccida is a little bit retracted, so the lateral process of the malleus is more prominent on case number 2.
okay.
So we need to evaluate what happened inside the epitympanum, maybe using CT scan if
Okay.
we want to use EES. That's my comment.
Thank you. Dr. Philip, maybe you can add some critical identification for the physical examination.
So I generally agree with what Dr. Harim has mentioned. We need to do a proper pure tone audiometry to check the airborne gap.
Okay.
We want to know whether there's any ossicular discontinuity, especially in case 3, where we see resorption of the handle of malleus, and sometimes the handle of malleus is sort of medialized and attached to the promontory. So in such cases, we can actually put the endoscope in and sort of release that. So that will actually improve the mobility, and then do a tympanoplasty. So I think yes, looking at the middle ear mucosa looks quite healthy. So in such patients, yes, I would proceed with the laryngoplasty. So if there was granulation, it was diseased mucosa and all that, I would do a CT scan. Normally in this kind of cases, routinely, I will not do a HRCT of the temporal bone. But let's say there was a lot of granulation, diseased mucosa, then I will do a HRCT just to make sure whether there's also a chronic mastoiditis process. Then I may consider doing a cortical mastoidectomy as well for the patients.
So you perform the CT in all cases of perforation?
No, only for those where there's granulation or diseased middle ear mucosa.
Okay.
Healthy mucosa like this, I won't do. I won't do a CT scan.
Only from the physical appearance,
Yes,
or
from
also with the audiometry result?
From the physical experience and the patient's history. This one is just intermittent discharge and it looks quite healthy inside. I won't do a CT scan.
Oh, okay. So you not always perform the CT scan, especially if it's really dry here. Okay. Hello, Professor Insect Moon.
Hello.
Hello. Nice to see
Yeah.
you again.
Yeah, I can hear you very well.
Can you hear us?
Yes, I can hear you very well. How about
Okay.
you?
Okay, I can hear you also.
Okay.
Okay, I present 3 cases of the perforation in pars tensa. Can you give some comment about this kind of clinical appearance of the patient?
Yeah, can I have one question? Can I ask one question? You present the hearing level. That hearing level is just air level or just you mean the first patient is 27 decibel, second patient is 37 decibel, and last patient I don't know, but anyway, that
About
means
45.
yeah, that means the airborne gap is that level or just the threshold is 37 or the airborne gap difference is 37, 27 or 45.
Okay.
Yeah.
So, is there any correlate? Can you give us some comment about if you found this case, this data first, and what is your next plan to add another data?
Yeah, I mean so 27 decibel is in the first patient. If the hearing threshold of the air conduction threshold is 27 decibel, is I think is acceptable, but
Almost normal.
airborne difference is a 27 means it's a too big difference. How about it's a you mean the 27 decibel means airborne difference or just a threshold? Is my question.
Oh, this is the threshold, and the conductive is less than 20.
Oh, okay.
I mean about 20 decibel, about 25 decibel.
Less than 20. Yes, airborne gap is not so big.
Pardon?
Okay. I mean the air conduction threshold and bone conduction threshold difference is not so big, not so different.
Oh, okay. I'm sorry, I can give the picture, but the air
Okay.
the air is about in 0, and the bone in about 27.
Okay, I see. So in first case and second case, I think looks middle ear is very clear and the population is very small. But in second case, spiral pie can be some kind of problem. But for me, in this case, I think we don't need to take a CT scan, and the meninoplasty can be enough treatment option. But in my country, CT scan is very cheap, and whole the national insurance cover the CT scan, so it's routinely we do the CT scan, but medically is not needed. And the third case, malleus is very short, and ossicle can be not intact. So I think we need to take a CT scan and evaluate before the surgery. Yeah, it's my that's my comment.
Okay, thank you, Prof. Insekmun. So for case 1 and 2, all panelists, if prefer to not, might be not really necessary to perform CT scan, but in the third case, I think it's a must to perform the CT scan because it looks like something happened behind the eardrum or in the attic area. And we can see there is a destruction of the malleus, and there is also a bigger gap in the conductive hearing layer. So all the patient, we have the CT scan, and so we can next data we can get like this. This is the first question for axial section. Please give a comment first, maybe Dr. Harim, for first cases.
Yes, thank you, Dr. Diana. So from this CT scan, we can see that pneumatization of the mastoid is quite good, as and extensive as well. And the most important in regard to this simple perforation with hearing threshold at 27 decibels, I will directly evaluate at the area of epitympanum on the coronal section.
Okay.
What I want to see is the condition of Broussard space
Okay.
and also the area in the middle of the incus.
Middle of the incus.
Because I need to know if there is cloudiness or opacification medial to the ossicles. That means I have to make sure what possible pathology in that location.
Okay.
If it is not with a normal pars flaccida, it means there is no possibility of primary acquired cholesteatoma. Any cloudiness mostly caused by fibrosis, caused by previous inflammation, recurrent inflammation. With that situation, maybe later Prof. Moon or Dr. Philip can give advice whether do we need to take out that to make a better ventilation or we can leave it there. It's always become a very interesting discussion because to clean that area, especially in the middle side of the ossicles, we need to remove the ossicles and later we have to do ossiculoplasty as Dr. Philip mentioned in previous presentation.
Okay.
So that's my comment for this first case. Thank you.
Okay. Maybe Dr. Philip can give your opinion. And this is the, if you need the coronal, this one. Sorry. Oh, sorry. It's already. This is the axial and coronal.
Okay, so I agree with what Dr. Harim has mentioned. This is a well pneumatized mastoid, and so it's well ventilated. Even the middle ear looks good. Then Broussard space area is okay. There's no blunting.
This one, right?
There's no blunting of the scutum. So I think this is a good case just to do a simple meningoplasty.
Okay.
So for me, it's quite straightforward. That's what I would proceed.
Okay.
If we found some cloudiness inside the area around the ossicle, do we need to?
Okay, so I wouldn't touch the ossicles because with just 27 dB hearing loss, because when you remove the ossicles, there's always a chance things will get worse. So finally, my view is not to make things worse for the patient. And if this side is 27 and the other side, I presume, is normal, the difference is actually not noticeable by the patient. So just leave it alone.
Leave it alone. Okay. What Dr. Harim said is maybe this position in the middle of the ossicle, right, Dr. Harim? Yeah, we can see this is quite clear, and so there is no pathology middle of the ossicle. So what the Dr. Harim also said is about the Dr. Philip is here in the Broussard space, and we see the scutum is okay, and the Broussard space there is no pathology, and in medial of the in the middle of the ossicle is also pneumatized and with a clean air cell. Prof. Insect Moon.
Yes.
Do you have any opinion about the CT scan of the case number 1?
I have no other opinion. I totally agree with the other panels. It's a well pneumatized bone and it's very clear around the ossicle, so it's no needed about no more opinion.
How about in this section, this picture? Like, can you see the arrow? My arrow? Yeah.
Yeah. I see.
Can we predict the ossicle change from this this picture?
Yeah, it looks looks intact, but we don't know. We cannot tell. Only the CT scan, because sometimes in the CT scan ossicle is intact, but in the middle ear, the mobility is sometimes not so good. But I don't know. But it looks good.
Okay. From the physical examination and then from the hearing function and also CT scan, do you agree that in this patient is only performed laryngoplasty? Dr. Insekmun?
Sorry.
Do you agree that in this case we just need perform a laryngoplasty?
I'm not sure because this patient suffered from the otitis media effusion. You mentioned that the population is from ventilation tube insertion. Is it right?
Partial from the ETF, the partial obstruction of the eustachian tube from the ETF, from the eustachian tube function.
Not from the T tube. I mean the
From TF2, yes, from TF2.
yeah. Sometimes if we do the laryngoplasty, patient can suffer from same problem as otitis media effusion. So we need to discuss about some possibility of otitis media effusion recurrence. Then patient agree to the laryngoplasty and she want to hearing gain. We can do the laryngoplasty. Yeah,
Okay,
that's my yeah.
Okay, I think it's a very important to give the right informed consent before the surgery for this kind of patient because the patient has eustachian tube that we afraid that after laryngoplasty there is still the same problem happen again, right? But if the patient choose the laryngoplasty and we can see that the perforation in the anterior part with this kind of size. Could you give your opinion, Professor Insekmun, what kind of laryngoplasty would you plan for this patient?
I usually use butterfly cartilage inlay laryngoplasty. Is make a cartilage, harvest the target cartilage and make a cartilage like a button graft and insertion like a ventilation tube because the population is very small and anterior side, so we can do the that kind of method. It doesn't need tympanomeatal flap elevation, and it's a very easy to do. So I think we can use the that kind of mass graft material, and endoscopic is better.
Okay. How about Dr. Harim? Do you agree that this kind of cases is a good case for a beginner in the endoscopic ear surgery?
Yes, of course, it is a simple case that we can manage using endoscopic ear surgery. In regards to the technique of tympanoplasty or laryngoplasty in this case, we have to consider that with this small perforation, as we know, we need to refresh the edge of the perforation. The technique I will use depend on the size after I refresh the perforation. If the edge, the anterior part of the perforation after the freshening is very close to the annulus, maybe it's not favorable for cartilage. But if there is still distant, some fibrous layer of the tympanic membrane is still much enough, then I agree with Prof. Moon that I will use butterfly cartilage tympanoplasty.
Yeah.
But I need to inform the patient that if I close that area using cartilage, if after surgery it develop otitis media with effusion, then I will ask permission to put the grommets maybe on the posterior side. Or if the size, I will consider as well to measure the exact size of that perforation. if the perforation size not bigger than a chromate tubes, maybe I will suggest patient, as long as it's not draining frequently, maybe we observe for few months ahead. I don't know, maybe I need comment as well from Dr. Philip and Prof. Moon, because if it's very small, I think it won't be different with we put a grommet tube there.
Okay. So just let the perforation. Maybe. Okay. How about you, Dr. Philip?
Okay, so based on the history that you
Yeah.
gave earlier, this patient has got recurrent discharge. So,
Yeah.
so that's why I would think of closing it. So I would do a tragal pericondium onlay graft. I would refashion the margins, scrape the epithelium surrounding the area, and put
Okay.
an onlay graft for this patient.
So you choose the only meringoplasty. So do you think the only meringoplasty will be suitable for a beginner for endoscopic ear surgery?
Yeah, for endoscopic, I think it's very good. I think like the video I showed earlier in my presentation, because the worry about the graft sinking in, so it is nicely placed. As long as you firmly place it on the eardrum, and then it will re-epithelize very nicely. So I think for beginners, it's important that you want to do cases where you see a successful outcome.
Yes.
If you start doing 1 or 2 cases and you see all fail, then you become demoralized and you think, hey, why, all my cases are failing. And then sometimes you give up, you don't want to do. So, so cases like this, do with a method where you will get success. Okay, so it's good and you get a good outcome, and it will motivate you to, do more cases.
But so many comment that in only when we elevate the epithel, it's more delicate than we perform the underlay technique. So how is your tip and trick to make the only meringoplasty is easier?
So for me, if you look at case 2, that patient has got tympanosclerosis. So then probably the other part of the tympanic membrane, it lacks the fibrous layer.
Yeah.
So in such a case, you try to do, actually you'll end up with a very big perforation. So for that, those kind of cases, I will not do a onlay. So it's probably better to raise a tympanomeatal flap, because the thing, it will tear. From case 2, from what I see, it will tear very easily. So it is not good to do an onlay method. So here I see it looks nice and thick. So it looks like the fibrous layer is
Okay.
present. So
Okay.
cases like this would be good to do an onlay.
Okay, that's very interesting. Now you can see that so many options. Even for meringoplasty, we have so many consideration. Okay, we go to the next case with the CT scan of the case number 2. This is the case number 2 with central perforation and tympanosclerotic. Maybe, and this is the axial slice, and this is the coronal slice. Okay, maybe the Professor Moon, could you give the opinion about your planning in this case? There is a tympanosclerosis, and this is the coronal, and this is the axial.
Sigmoid sinus is a little bit prominent, and the tegmen is a little bit lowly light, but pneumatization is well, the mesoid cavity is well pneumatized, and occipital looks intact. So I think we can do the meringoplasty, but the tympanosclerosis and the sclerotopy can be some problem. We can use several techniques. I also prefer butterfly inlay cartridge meringoplasty. Even the sclerotopy is used, but routine in mostly standard techniques on underlay meringoplasty, underlay graft.
Will you remove all the tympanosclerosis in this case?
Yes, standard technique is we need to remove all the sclerotopy, but if I use butterfly technique, I don't remove that sclerotopy, just trimming a little bit can do the innate technique, but if I do the underlay graft, I try to remove as much as possible.
Okay, so the problem for a beginner is sometimes when we remove all the sclerosis and then the perforation become bigger, and that makes for a beginner it's that makes me difficult, and then the next. But it's very important to refresh properly to make an epithelialization is good. So how about Dr. Harim? Do you agree that we should, in your experience, will you remove all the sclerosis, tympanosclerosis like this?
In my in my practice, I agree with Prof. Moon. What we consider in this situation that in that sclerosis area, the vascularization is so bad. Can we call it maybe relatively avascularized? So if you perform any grafting, as we know, we need a good vascularization. So my suggestion is that you remove all those sclerosis area, and that's true for beginners. Sometimes they avoid to make bigger perforation, but actually that's not right. In sclerotic tympanic membrane, it is a useless skin. So it is better that you make a bigger perforation, but later you will get a better vascularization, neovascularization, and the healing process.
Okay.
So I will remove all those sclerotic area, and we can replace it whether using cartilage, composite, or perichondrium.
So you will perform the underlay tympanoplasty also?
Yes, because I have to remove all those, and I will also focusing on the area of pars flaccida. If they're so thin and there's a mild retraction, I will put maybe a very small cartilage just to prevent later retraction.
Okay. How about Dr. Phillips?
Okay, so again, I would do an underlay. So the choice of whether to remove the tympanosclerotic patch, it will depend. So what I find is, as you are refashioning the margin, as you're lifting, somehow or other, it breaks or something, and you will be forced to remove it. If I can preserve, I will preserve. But if I have to remove, I will remove it. Okay, and then I lift the TM flat and I do an underlay meringoplasty.
Okay, and so all the participants agree that they will perform the underlay technique, right? And so how about the incision of the tympanomeatal flap? Will you perform from a 12 to 6, or you will going to a little bit anterior from the malleus in this kind of case, because we want to reach maybe the better flap for the anterior? Maybe Dr. Philip?
So I would do 12, maybe inferiorly, I may extend a bit more anteriorly.
Oh,
that means maybe to 5, or just to lift the whole thing up.
From the
around there, yes.
Like this?
Yes.
To 12, okay.
Yes.
Okay.
Yes.
Maybe Prof. Insegmun, do you have any preference in incision of a tympanomeatal flap in this kind of case? Should we perform it from a little bit anterior, or just enough from 12 to 6? I'm sorry, I can't hear you. Maybe.
I'm sorry.
Okay.
I was muted. I think 12 to 6 is enough, but sometimes during the removing the sclerotic tophi, the population can be bigger. At that time, we can make incision, make the extension, but the initial incision is enough for the from 12 to 6.
Okay, and we have to elevate the tympanomeatal flap from the malleus, right? So it's, I think, for a beginner, this is also the challenge to to elevate the tympanic membrane from the malleus. Do you have any tip and trick to safely remove the tympanomeatal flap from malleus?
Yeah, it's very difficult to detach the tympanomeatal flap from the malleus because during the detachment the flap from the malleus, we sometimes, in many times, the flap was teared, or the remnant is remained onto the malleus. So remained skin can make epithelial pulp, or the tearing the membrane is making difficult to meringoplastic. So I use everyone has their preference, but I use a sickle knife and detach the flap from the malleus very carefully, and very carefully grabbing using the forceps, and in the umbo area. Just scissoring. Scissoring is better not to damage to the ossicle because sometimes too strongly pulling or strongly handling the ossicle malleus can damage to the ossicle chain, and also damage to the staples.
Okay, so that's one of the tip and trick using the sharp instrument, and then we have to parallel with the malleus from the neck to the umbo. That's the secret to not, so because we can in this step we can make a problem with the ossicle if we do not very carefully elevate the tympanomeatal flap from the malleus. Okay, we go to the
Just one more thing I would like
yeah,
to add about
please.
that case.
Okay.
Sometimes when your perforation is maybe a little bit more anterior,
Oh, yes.
when you refashion the margin, you can see it. But the problem is your scope has a wide field of view. But your instrument, when you put in your instrument is straight, your instrument cannot go and reach the angle.
Okay.
So in that case, if the anterior hump is a bit high,
Yes.
I will actually drill down the anterior hump so that it gives me better access to the anterior margin.
Oh, okay, that's interesting. So when we perform the canaloplasty in the AS for in anterior part, can you give us some condition for that?
So like this, when my instrument cannot reach the anterior margin, and then when I see a hump like this, and that is obstructing my view, then I will drill down the anterior hump.
Is that the reason that why you make the incision more the
Yeah, so that is
anterior?
why sometimes I go a bit lower. Yes.
Okay, so if you want to reach to remove some bone that is will obstruct our work, we can do the canaloplasty first, and we can extend the incision to more anterior, right? Okay, that's a good tip. Okay, and then yes. Oh, okay. Okay, for the participant that would have any question, you can join the question and give the question in this session. Okay, and then we go to the third case. Okay, this is just illustration. If in one, the first one and the second one, if with that kind of CT scan, this is what we will find that there is no problem with the mucosa, and we see that there is a good connection between the malleus, incus, and stapes, and there is no problem with the isthmus tympanic. And so that's why in the first case and second case we don't have to touch any area of this, because the problem is only limited in the tympanic membrane. Okay, and then we go to the third case. So this is the third case CT scan for axial slice, and this one for coronal slice. Maybe Professor Moon, could you give the comment for the third case?
Yes, in the CT scan, the granulation is filled with the mesocecal cavity, and the attic area was filled with granulation, and the malleus handle was eroded. So there are some possibility of ossicular chain damage, and also the granulation is interfere the hearing. So I think we need to remove that granulation and checking the ossicular chain mobility, and also we need to solve that problem, and also do the tympanoplasty.
Okay, thank you. So the problem is beyond the tympanic membrane, and could you give any additional comment, Dr. Harim?
Yes, Dr. Diana, thank you. In regards to the opacificity inside the antrum and the mastoid air cells, it could be caused by the granulation, as Professor Moon said, but maybe it's also a fibrosis tissue. If it is a fibrosis tissue, and I do mastoidectomy, example, for to remove that pathology, and I found that there's a fibrosis tissue. Later, after surgery, maybe months later, if we do CT scan, it will come back again. So mostly it won't be different between before and after. That's why always a challenging situation in this kind of clinical presentation, whether this opacification is caused by fibrosis or granulation. If it is a granulation, that we need to clean up that pathology or any infection inside, as Prof. Moon said. But if it is a fibrosis, I'm not sure whether we will give an improvement to the situation of the middle ear. But what I want to say that from the otoscopy, we can see that the mucosa of the promontorium is complete, almost normal, and there is no secretion pus. I think the opacification is caused by the fibrosis, but we need to prove that. And from the coronal view, can you show the coronal view?
Okay.
It's look like the Prusak space in the upper picture. The Prusak space is filled with air. Yeah, it's a black. But on the medial side, there's something filled that area. That's what I mean. In this situation, maybe we need to remove the ossicle. If I open this mastoid and also to clean up the middle ear, I will remove as well the ossicles to clean up all the pathology, and I will do the ossiculoplasty.
Okay. Because from the CT scan we cannot differentiate whether it is a granulation, fibrosis, or cholesteatoma, right? So that's the possibility that might be the prognosis that for our strategy in surgery. Yeah. So how about the ventilation route in the patient, Dr. Philip Rajan? Do you have any comment about this patient?
All right. So from the beginning itself, a patient like this, I wouldn't have done a CT scan because the middle ear mucosa is healthy. But if I had done a CT scan and I see this, then I'm forced to go in because I can't really say what it is, So I will have to do a cortical mastoidectomy at least for this patient. But having said that, there are published papers, whether you do or don't do a cortical mastoidectomy, the outcome is similar, So so the question is whether we would do it or not. But since the CT scan shows some opacity in the mastoid, and it looks like it's a bit of a destructive kind of lesion, I would have to do a cortical mastoidectomy for this patient. And like what Professor Harim also mentioned, I would look at the middle ear, look at the ossicles, and see whether some work needs to be done there.
Okay. So how do you perform the surgery? Do you prefer using the endoscope for transcanally?
Okay,
so how the step?
Okay, so for me, generally from what I've seen, most like this subtotal or near total perforation, usually the ear canal for some reason is big lah. I don't know what is your experience. You know,
Yeah.
more subtotal perforations you see, they have a good space of ear canal. So it is a good case to do with an endoscope. And in cases like this, nowadays what I do is I will do a 360-degree removal of the medial ear canal skin.
Oh,
Completely, I will remove everything.
oh, okay.
Okay, and then I put a graft. I don't put a cartilage graft because sometimes it then just blocks the whole thing. The graft is quite thick, so I've used a temporalis fascia and then re-put the skin on top of that again. Okay, so that's what I do now for my like this near total, subtotal perforations, large perforations.
Oh, okay. So you remove the incus also in this step?
So I would look and see, yes, if there's granulation, all that, then I would clear up everything. Because I would do a cortical mastoidectomy, remove the disease from the mastoid, clear the endrum, clear everything. I clean everything.
And how you clean the isthmus area? Would you do this with the endoscope or by microscopically?
So the middle ear work will be entirely endoscope.
Oh, okay. So you will work for, until the attic with the microscope.
No, from the mastoid region, that from the back I open, I do a posterior atticotomy. I will open up from the back.
Oh, so you will clean the attic from posterior.
Yes.
Oh, okay. That's interesting.
So I will put the endoscope from the mastoid to see how much the disease is extending. You can put an endoscope in the mastoid and see how far it's extending anteriorly.
So in this case, you will doing the combined endoscopic microscopic approach to reach the tympanic cavity endoscopically, and then you remove the incus transcanally, and then you perform the mastoidectomy transmastoid and use and continue with the atticotomy transmastoid and clean the combination this tool. Okay, this is very interesting. Prof Moon, could you give your opinion how your step in surgery in this kind of case?
Yes, my first option is tympanomastoidectomy. I mean the mastoid cortical drilling plus granulation removal, ossicle removal. I mean the incus removal plus sometimes in this case malleus removal is also one of the options. Then do the ossiculoplasty. That is a first option. And second option is also endoscopically incus removal and middle ear granulation removal plus ossiculoplasty and meningeoplasty together. Because as you know, the isthmus is a most big problem, but the ossicle is very, very important. But if the ossicle is not functioning, if we remove the ossicle, isthmus is very, we can make a very big isthmus. So sometimes the ossicle is as an obstacle for the isthmus. So if in this case, malleus is already eroded, incus is surrounded by granulation, we can remove the ossicle and that can give us a big solution. Yeah.
Oh, okay. So we agree to complete the eradication of the pathology. We can perform endoscopically, transcanally, and then for the rest of the mastoid, it could be a fibrosis in this area. So we can reach this area because it's too far to clean this by microscope transmastoid. Okay, maybe is there any question for this kind of cases from the audience and the offline participant? No? Okay. Okay, maybe we continue with the next case. Okay, I think we just discuss about all this question, and then we go to the third. Okay, and this is the third case. Sorry, I will share for the third case, the case number 3. Actually, in this case, we can see this is the mucosa and I will perform the trimming of the perforation, and then I elevate the tympanomeatal flap, and then you can see the destruction of the malleus. This is the same with the CT scan and also the clinical appearance from the beginner, and we see that in the tympanic cavity the mucosa looks okay, but looks like there is a fibrosis and granulation around the stapes, and it's a very thick, and we have to be carefully. And this is the round window, and this is ponticulus subiculum, and this is sinus tympani. So I try to release the fibrosis using the cutting, and then perform the atticotomy transcanally. So I open the attic from transcanal, and now we can see the granulation, and this one is we identified the incus, and the incus, we see that there is a destruction. So the incudostapedial joint has not there is no connection again. So, and then we have to make sure first the incudostapedial joint, and then we dislocation malleoincudial joint, and then we remove the incus. So there is the ventilation problem. We can see here the ventilation route, and we see that the mastoid just only not really just a little bit of thick mucosa, and also a secretion. So I not decide to do the mastoidectomy in this case. So I just perform clean the ventilation route, because from my view with the 30-degree, I'm not see any more pathology that we should remove in the tip of the mastoid. And then the challenge is how we clean all the pathology in isthmus tympanic that cover the granulation around the stapes, and this patient has a conductive hearing loss, and I don't want to be a sensorineural hearing loss, of course, but this is the problem in the JOSM. We have to clean the ventilation route to make ear become dry, and this is I try to clean, and like a Dr. Harim said, that it's going to the anterior, and we identified this is the anterior crura, and I use the Panetti set like Dr. Philip, so it's very helpful. I using this kind of instrument to clean all the pathology, and also using the patties like this. It's also I don't know if I don't have a patties, if I perform the EAS actually, because of neuropathies is very important in EAS. And then we remove the anterior. See the obstruction is very big, quite big, the anterior part, and we clean all the pathology around the anterior part, and we see the mucosa quite clear enough. So I'm not so I decide to not perform the mastoidectomy, because I can see cell here, and this is a facial nerve, and then we also clean the supratuba area. This is the place where the tensor folds area, and then we check now the condition of the ossicular change, and then we reconstruct. Okay, maybe this is what I decide to the patient. Maybe is there any comment for the management like this? Is there any something that I have to consider in the future after I perform like this? Maybe Prof. Insekmun? Please.
Yeah, I think it's a very good surgery. Well, yeah, it's wonderful surgery. And did you do the ossiculoplasty? Not do in this time.
Yes. So and then I reconstruct the cartilage and mucoperichondrium. So I just left the one side of the mucoperichondrium, and then we have this is a chorda, and I don't have enough one piece of cartilage, but I do have, and I make also interposition of the incus, and I put the incus interposition and fixation, and the ventilation is we hope it getting better by perform this, and then I perform like a palisade for the rest of this is I put some cartilage to make the level of the tympanic membrane in the same level, so we can move the ossicle, and then because I use the scissor, so some scutum bone I could replace again in the scutum area, and then I put the the other side of the mucoperichondrium, and then with replace again the tympanomeatal flap and make sure all the graft has covered all the perforation. Please give some comment, the Prof. Moon.
I think it's a very nice surgery. It's very good, and if a patient has a hearing improvement, the surgery is perfect. But if the hearing is not improved, we can second look examination. But anyway, congratulations, wonderful surgery.
Thank you, Professor Moon. Okay. Is there any more comment from Dr. Harim or Dr. Philip? Okay.
So I suppose the only other thing is that if you whether the ossiculoplasty is going to be a stage,
Okay.
you know, whether we want to do it as first stage or second stage. So I think that all depends on what you have. Like in Malaysia, we never had tops or pops, and those are expensive.
Same with my,
you know,
my hospital.
So of course now recently those things are available. So now I think some of these procedures I will do it as stage procedures, you know, and then maybe see everything is healed nicely, clear, and then maybe at the second stage go in and try the tops and pops, which I've never had the experience before, but you know, that is something you can think about.
Okay, thank you. Okay, we go to the last case. Okay, this is the case number 4. It's a male, 42 years old, with the ears discharged more than 3 months and hearing problems, sometimes a headache, but not a dizziness. The right side is normal, the left side is conductive hearing loss, 36 dB, and this is the appearance of the physical examination. Please give some comment, Dr. Harim.
Yes, thank you, Dr. Diana. From this picture or video, we can see that the lateral wall of the epitympanium has already gone, eroded completely, and we can see the head of the malleus with the absence of body of the incus maybe. And for certain, the long process of the incus has already completely gone, and the tympanic membrane was attached or retracted towards the head of the malleus. Stapes.
stapes.
So
Yes,
just
yes.
like
This is the stapes. We can see the stapes.
tympanoplasty
Yeah.
type 3, right? Natural tympanoplasty type 3. So in this situation, because the epitympanum has already opened, if I don't have CT scan in this patient, I would to evaluate using 30 degrees endoscope
Okay.
to see towards the antrum from the opening of the epitympanum or scutum, and I will evaluate whether there is a pocket retraction towards the medial side of the head of the malleus. And if the incus has already eroded or only left of the body of the incus, I will remove it to make sure that there is no cholesteatoma matrix medial to the ossicle. And I will preserve the long process of the, handle malleus, and I will cut the head of the malleus at the level of the neck. And later reconstruct the epitympanum using composite graft from the trachea.
Okay, maybe Dr. Philip, could you give your comment about this kind of physical examination?
Looking at this, the attic is destroyed. So for me, this is a cholesteatoma, and what we probably will find on CT scan is usually a contracted or sclerotic mastoid, and the cholesteatoma will be inside the antrum. Okay? So in a patient like this, I would do again like combined approach, atticoantrostomy, and what I do nowadays is I do a cavity obliteration with demineralized bone. So I will just seal up the mastoid antrum and then graft the attic region.
Okay, I will give the CT scan of this patient. Could you give, this is the axial, and we see a slight soft tissue like this, and looks like the attic part is good, and there is a cell also lateral to the canal is semicircular canal, and this is the coronal view of the patient, and we will see soft tissue very limited here in this area. Please, Prof. Moon, give some your comment about this condition and your planning.
Yes, I totally agree with Dr. Harim because also in the CT scan, it is same as a physical examination. Also, the attic is a severe adhesion and is progressed to the cholesteatoma, and incus is also already eroded. So I think we can remove the malleus head and remnant incus and ossiculoplasty and attic reconstruction with cartridge. But without the tight reconstruction, the adhesion and cholesteatoma is recurred. So I think endoscopic reconstruction is enough, but the tight reconstruction is needed.
Okay, so will you perform the surgery endoscopically or microscopically in this kind of cases?
Yeah, I think we can do it in this case, the endoscopically.
Okay, how about Dr. Harim? Or
Yes, as you mentioned on the upper left picture, there is maybe the posterior border of the cholesteatoma sac.
yeah,
If you can suck that out
yeah.
and can remove the epithelium layer completely, maybe you need just to open more posterior to expose more area of the antrum using curette or maybe drill. And after that, maybe I think I don't need to open the mastoid because it's very good, well aerated.
Yeah, this one. Okay. Do you perform the endoscopic Philip too, Dr. Philip?
For me now, this kind of cases, I will go through a post-auricular approach, and I will do an echoenterostomy.
Anticoantrostomy. Oh,
Because
okay.
what I find is it is so much faster.
Oh, okay.
It's much faster than
Okay.
doing endoscopically, you know,
Okay.
by clearing blood bleeding and all that. You know, it's so much faster. Just do a post-auricular approach
Okay.
and just do an echoenterostomy, clear out the things fast, and then with a bit of canalplasty, and that's why I obliterate the mastoid cavity after that.
Oh, so the mastoid will be a big, and then post-operative it will be bigger. So it will be, and finally will be like a kind of wall down.
So what I do is I've opened up the antrum. Okay, so now it's like a sump there. So that is why I obliterate. So it is a canal wall down,
Yeah.
yes, but then I obliterate the
But
cavity.
you perform it anterior to posterior. Will you use the endoscope to as assisted endoscope after you make the articuloantrostomy?
So it depends on what I see. If I can see clearly everywhere, I will not use the endoscope. Sometimes I just use completely microscope.
Okay, that's a very interesting. And so we have some alternative in this kind of patient. So this is the surgery. So I start with the endoscopic first. And the first one is, of course, the infiltration. And then we perform the tympanomeatal flap, and the tympanomeatal flap will be go to the anterior because we have to explore the anterior epitympanum, and that's for sorry. And then we elevate the tympanomeatal flap, and we start the matrix. So the matrix attached to the skin of the ear. So it's very important to follow the ear skin from ear canal to the matrix. And this is the annulus, and we elevate the annulus. And this is the anterior part that we can see the matrix continue with the skin of the ear canal, and it looks like already acetotomy naturally. And so we try to follow the matrix, and now we see the pyramidal eminence and stapedial muscle and stapedial tendon, and of course it should be attached to the stapes. So, and then we work very carefully in this kind of place. We should use the forceps, micro forceps, and it should be a grab and not make the stapes move, but can grab and very well. And then I use the curette. I make it a little bit bigger, and maybe the question that sometime in the beginner, how big is your athecotomy? That's the. Can you give the answer, Professor Moon? How big is we should perform the athecotomy transcanally?
So we can expose a lateral semicircular canal till to the LSCC, but as there are no exact extent, but I think I try to make it bigger, but it's I think your surgery is quite good, but we can do till to the LSCC. Yeah.
Oh, okay. It's around LCCC. Is there any comment from Dr. Philip? How big is the athecotomy we should perform?
So one reason why I switch back to a post-auricular echoenterostomy is although the CT scan shows air pockets, actually you find that the cavity is lined by cholesteatoma sac. You know, so you may look, oh, CT scan looks quite clear, but that it is aligned, and then it goes a bit deep.
Yeah.
So if you just do purely endoscopic, sometimes you may not actually clear everything.
Yeah.
And that future cholecytoma might grow. So that is why I switched to a echoenterostomy, so that I make sure everything is opened up and I can clearly see everything. And if there's a lining of sac, I remove all that.
Okay. Dr. Harim, do you have any comment about how big is the athecotomy we should perform?
Yes, in regards to the size of the dichotomy, depend on the instrument of visualization you have. Whether you have microscope, whether you have only endoscope, whether you do the approach as Dr. Philip say, retroauricular access or transcanal access. If the aim is you need to visualize completely.
Yes.
All area from the epitympanum to the antrum,
Yes.
especially around the stapes, because most difficult site is in that area because
Yes.
there is a pyramidal eminence. Yeah, there's the track of the ventilation, so it will be challenging. So depend on the instrument or visual instrument you have.
Okay. Okay, maybe I will add some information from the expert. The consideration, another thing about the how big is the athecotomy is also how we reconstruct after we make it big. So we should consider how big it and could we reconstruct it after we make it so big. But it's the number one, we have to get a very good view of the area of the stapes and attic. And then in this case, I follow the matrix. And I try not there is not cut the matrix because it's very important. If we can remove it in total, we sure that we can completely remove all the matrix. But if it's there is a tears, and so it's a very difficult that we sure we can remove it completely. So in this kind of case, I agree that we have to ready if we need to change to microscope. If we will leave some matrix. We are not sure that we can remove it completely, so we should think about athecoanthrostomy or maybe for a kind of well-done approach. So I try using this is the curette, the curved curette, and I think this curette is very helpful because it's a very good working in around attic in going to antrum. And and then I found the incus, and the incus is already dislocation from the stapes, and now we see the mucosa in the attic is good, and we can see this is the facial nerve going from lateral to medial, and this is the canalis lateral semicircular canal, and so this must be the antromastoid, and we see good mematization, and our job is to follow the matrix. Can we follow this matrix? And then I still have a job to remove the pathology from the stapes, not completely. So I make it a bigger area first. So I have a space to remove the attic in the stapes area because I don't want make a problem with the stapes, and and working in this area, we need the curve instrument, and we can see the stapes, suprastructural stapes is very good. And I try using the sickle knife to remove the rest of the matrix, and then, but not easy. And then I try using a biopsy, a curved biopsy, to reach this, and then, and finally I use a pick, and now we can remove it. So the mucosa under the matrix is a very good condition, and And then this is the anterior part, and now I continue to, sorry. I continue to the antrum, and it's a very beautiful now. So I reached the last piece that attached to the posterior part, and I'm quite sure that it is intact removal. So and then I evaluate the mastoid with the 30-degree, and I think ideally with a 45, but I don't have a 45. So because the metric can be followed, and we can see the mucosa is good. So I follow so I skip with the endoscope. And then this is the retraction the entire part, and I also doing like Dr. Harim said that we have to remove the head of malleus because we see the matrix going to the anterior epitympanum. So we should remove the, we first cut with the malleus snipper, and then we incise the rest of the cholesteatoma, and this is in the anterior epitympanum, and then we remove the matrix, and this is the attachment of the matrix from the skin. We try to cut it with the scissor, and then we can remove all completely from transcanally. And of course, we have to evaluate very carefully. And so this is the rest that we have a pars tensa in anterior, and there is a malleus, half handle of malleus, the attic, the supraluba, and chorda. And then we try to reconstruct the area and make sure there is no more rest in the anterior part of, this is the supratuba and anterior epitympanum area. Okay, and then we perform the reconstruction by so we evaluate again, and this is the round window. This is a supratuberous, suprastructure stapes, and this is a facial nerve, segment tympanic. This is a anterior epitympanic. This is a cock, and this is a epitympanum. And then we measure the size that we should use to reconstruct the scutum here. And I use the cartilage to reconstruct the scutum, and I combination with, and I put, because there is a gap between the cartilage and the suprastructure stapes, so I put a little bit of cartilage, so the graph will be good position. And then I add some mucoperichondrium to the rest of the perforation and make sure all is completely covered, and we return the tympanomeatal. Okay, maybe the last, maybe I ask a comment from Professor Moon.
Yes. So one big piece cartilage reinforcement, and one big piece meningoplasty is very good for the prevent the the audition and cholesteatoma progression. It's a very big method, but it's a cartilage size is there are limitation of cartilage size. But if you have a little bit more cartilage, you can block attic. Is I think it's better.
Oh,
Yeah,
okay.
so but very good surgery and congratulations.
Thank you. Can give Dr. Harim a comment for the surgical?
Yes, I just want to add a consideration that in the situation of where we found retraction that severe, once I went to Belgium, to Antwerp, to St. Augustinus Hospital, who organized bone obliteration tympanoplasty,
Yeah.
they said that in that situation, whatever you do, the mucosa is no longer normal function. That means they recommend in that situation to reconstruct the epitympanum as Dr. Philip mentioned. We have to obliterate,
Oh, okay.
just close it, even the antrum itself, because
okay.
if you leave there, someday if the pars tensa is still a normal structure, someday it can produce a retraction
Okay.
from pars tensa towards the epitympanum that we leave it. We thought it is an aerated area, but actually it's sucking the gas and make a negative pressure.
Oh, okay.
I
What
don't know,
material would you suggest for?
At that time, they suggest
like if you have
using
this
bone
kind
putty.
of a quite big antrum, right?
But
And
maybe
what
we can
we
use
can use
the
what?
cartilage
Or more cartilage?
Yeah.
Where we can
just
get
to
it?
close the,
To-
so we don't let there is an air space in the epitympanum. I don't know, maybe Dr. Philip.
Do you have
may
any suggestion from where the cartilage is taken? Because
If we need
we need-
more cartilage, we can take it from the conchal area of the.
okay, cochlear area to
of the
to
auricle.
obliterate
Just-
the
we
cavity.
make it like a palisade, but the aim is to close.
Fill the
to
market.
fill.
Okay, that's good.
So,
Good idea.
So this is what I used to do at some time ago. So then what I found was because of the thick cartilage, sometimes in some cases it sort of actually blocks the antrum.
Oh,
When
okay.
we put a cartilage there, thick cartilage, and in some of revision cases, I find there's effusion and fluid collection.
Okay.
So that is why I decided to move towards obliteration, and why I straight away do a post-auricular approach. I do a bit of a canalplasty. So I collect the bone pate from there, which I use for my obliteration. And then I use demineralized bone. So there are a few options. This you have to buy. Sometimes the orthopedic surgeons use it. They use it for the small cavity defects. And the other option, I think in Belgium, they use bone glass, I think. Right? So there are a few options because the bone pate alone sometimes in a cavity that big is not enough.
Yes.
We need more volume.
Yeah.
So so I use bone pate that I drill out, and then also with the demineralized bone. So all that forms a matrix. And if even that also is not enough, sometimes I put a bit of gel foam, and then of course reinforce with cartilage so that it's the entire area is sort of sealed off. So that's what I do nowadays.
Okay. Okay. Thank you very much. I think our time is already over, and I think we have a very good discussion, and hope it will help all participants in their practice. And thank you very much for the panelists that they give you and share your experience in this kind of cases. So I will finish this session. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Bye-bye.
Yeah, thank you very much.
Check. Professor Moon, if you could wait for a bit, we'll take another photo with you as well
Yes,
on the screen.
yes. Okay.
Thank you very much, Professor Moon. Sekali lagi terima kasih kepada narasumber dan moderator. Thank you for all the moderators and the resource persons who've been helping in these discussions.
Dengan demikian berakhirlah hari pertama dari rangkaian acara Third Jakarta Endoscopic Ear and Sinus Surgery Course. Esok hari kita akan memasuki hari kedua dengan acara workshop Hands-on Endoscopic Ear Surgery, lecture on Endoscopic Sinus Surgery, dan Dexterity Training Module.
That last session concludes the first day of third Jakarta Endoscopic Ear and Sinus Surgery course. Tomorrow we will begin with the hands-on workshop on endoscopic ear surgery, lecture on endoscopic ear surgery, and dexterity training module, which is all going to be done in a small discussion group. Untuk lokasi, hands-on workshop akan dilakukan di Departemen Forensik Rumah Sakit Cipto Mangunkusumo. Terus udah kan?
Kami mohon maaf apabila selama rangkaian acara hari pertama ini terdapat kata atau perbuatan yang kurang berkenan.
We would like to apologize for the inconveniences that occurred during this event.
Sebelum mengakhiri acara hari ini, kami ingin sejenak mengucapkan terima kasih kepada para sponsor yang telah mendukung terjadinya acara hari ini.
Before we end our program today, we would like to express our most sincere gratitude to our sponsors. This event is supported by
PNG,
AMC and Stores,
Abbott,
Hyphens,
Mandara Medica, Surgika Alkes Indo,
Dexa Medica,
Megah Alkes Indo,
Medika Utama,
Hearing Vision,
Tunggal Cahaya Mandiri,
dan 2 Srikandi.
Akhir kata kami ucapkan sampai jumpa pada rangkaian acara selanjutnya. See you tomorrow for another session.